really prevalent in women particularly, so doing women's health, I see it all the time. And when I first started practice, I didn't check vitamin D levels because it wasn't something that was well covered under insurance, and it's not really something that you learn in school. Hopefully they're teaching you all that, and I will teach you that you should be checking vitamin D levels on like every single patient. I have never seen a normal level of vitamin D in a patient who isn't supplementing, like ever. I mean, that just has not happened. We really moved through our storage of vitamin D in stress. And the world's kind of stressful. So, there's definitely a connection. And during COVID too, we found that those with vitamin D levels that were sufficient seemed to move through the virus better and have fewer long-term effects than those with depletion. And most people are depleted. So there's definitely a connection. And with Hashimoto's or autoimmune thyroiditis, vitamin D levels are really, really important to check. So really make sure you check that in all patients, not just for female patients. So it's a great article. And I think we're going to learn more and more about that as we start to focus on vitamin D. Vitamin D kind of acts more as a hormone. I like to think of it more as like a hormone because it impacts the way all of our other hormones function than just like a vitamin that you need. So if you don't take vitamin D, everyone who's listening, take vitamin D.
In what way do you tell your patients to take it? Like mine is always low. And so I did like the tincture, the drops, thinking that was going to be better. And I don't think I was consistent enough with it. So it was still low. So I finally just went and got like gel-filled capsules. Like at Costco, they're probably garbage. And then she told me I need 5 of them a day, like 5,000.
Yeah.
What are those called?
They're IUs, and they actually switched them to, I can't remember if it's milligrams or mcgs. They switched it over to a different unit, which I can't wrap my mind around because I've practiced in the IUs for so long, but it is a different unit. And they have a conversion that you can just easily look up. But most people need between 2,000 and 5,000 a day.
That's 5,000 they told
me.
But
vitamin D is fat soluble. So I actually tell patients, I take mine once a week because it's going to like build up in your kidneys. So the only patients that you have to be really careful about with vitamin D are those with renal disorders or disease. Yeah. It has to be pretty bad though. I mean, we're talking like GFR is really low. Otherwise, they can tolerate it. You just have to be careful. Like, don't go to those higher levels and test them. Like, test them every 3 months to make sure it's not impacting it. But I think it's easier to remember to take something once a week. So I usually have patients like every Sunday they're going to take their dose. So, if you think if you're taking 5,000 a day, then you take 5,000. Yeah. So the high dose prescription of vitamin D is 50,000. Yeah.
I'd rather take it once a week.
So you can also counsel people to take it once a week. Again, just be careful of like what their kidney function is. Because somebody who has kidney dysfunction, they're gonna just have to take it every day. Because you don't want to just snack their kidneys with a really high dose of vitamin D. But for a healthy, normal like us, it's time to do that. So, and if you're like, I don't know, then take 10,000 once a week, get your levels tested, see where they're at, and you can repeat test them every 3 months is fine. No sooner than that, though, it takes time to get to build up. And you can bill it under fatigue, right? That's somewhere like sneaky. You can bill anything under fatigue, and we're all tired. So the world is a tired place, so everyone you see is tired.
So you can build it on the fatigue. So your physician has to be willing to do that for you because they don't do it. Yeah. You usually charge you that copay or that because insurance don't cover it.
Yeah. There's still like as far as I've been,
they just test mine annually at my well check.
Fatigue is one that usually the insurance plans will cover it.
So I would have to tell them because I'm with vitamin D and my son is right in my house. Yeah. But they don't we pay for it.
Yeah, tell them. Yeah. Be like, could you add fatigue? Yeah. I mean, a patient could absolutely tell me that or ask me, and if it's appropriate, I will do it.
I don't want it.
I'm sure you're tired. You can be like, I'm in the nurse practitioner program. I'm tired all the time.
She does dialysis at like 4 in the morning. She's crazy.
Yeah. So you're tired. So
I'm tired.
Just ask if they can try. Just say like, I've been getting this bill. Could you try? Would it be possible to bill it under fatigue? Because I heard that maybe it might be covered.
I will.
I found an interesting article, and it's interesting because my poor little sister who's pregnant with her 4th baby is having all these hyperthyroid symptoms and they just tested her and they're saying she's hypothyroid. She's having like heart irregularities and tachycardia and like profuse sweating with like BO, and she never smells, like this poor girl. So my article was on, when she did just have a miscarriage before this pregnancy. So mine was looking at a comparative study between recurrent miscarriages resulting from thyroid dysfunction and autoimmune diseases. And it basically just said that those with autoimmune diseases, this is not the same, those with autoimmune diseases are more likely to have recurrent miscarriages than those with thyroid disorder. But I really was just trying to find answers for it. I didn't find it in this article, but there was other scary articles about things that she's dealing with. Poor girl has no answers still. Not for me, not from doctors, no.
And that's why, like, just in terms of hormones, when you're talking women's health, thyroid to me is just like a no-brainer that it's something that you check on all of your female patients.
But it's
like,
not this, but this study, which was like 2021 to 2022,
so there wasn't a correlation.
Said that it's not recommended that all pregnant women, so it's pregnant women, so you're saying women, that all pregnant women have thyroid.
So,
is that interesting?
Yeah, and I think that, I think there's truth to that only because when they're pregnant, everything changes, right? Like,
yes.
So patients that have MS or have other autoimmune-like conditions, a lot of times during pregnancy, they go into complete remission. Like they don't have any symptoms during pregnancy. And I think, and we'll see, whatever, there's so much about hormones that we don't know, but I really think that it has a lot to do with progesterone. And we'll maybe get into this a little bit when we do gynecology, but because progesterone is really, really high during pregnancy, and progesterone is a really amazing hormone. So I think there's probably some connection with the elevation of certain hormones during pregnancy and then the production of autoimmune antibodies. So
basically you see a reduction of the autoimmune. Yeah, that was interesting.
Yeah, I mean, and you guys might be able to think of somebody that you're like, yeah, they were pregnant and they were like doing a lot better. Like things were just, you know, not diabetes so much. Diabetes is not better, but
it's her best time was when she was pregnant.
Yeah.
Who had autoimmune? Like
no, just like in general, like her depression symptoms, everything was much better.
Interesting.
Progesterone.
But it did say that something during pregnancy, and maybe you know, almost acts like TSH, like does the same type of, I don't remember what I read. I had so many things pulled up here. I thought that was interesting that it could almost like mirror that, but it's not that. And hormones, like you said, just like
thyroid's tricky, too. So let's see, I got one comment in here. Oh yeah, and Linda said that she usually diagnoses vitamin D under vitamin D deficiency, which will work once they have vitamin D. Once your vitamin D is low, you can use that, but to get it covered, like you can't check it and have it be low, insurance won't cover it, which is like the stupidest thing in the world. So you have, the fatigue works really well.
Fatigue, then it's low, then you can.
Then you
deficiency.
Yes, it's just, you guys, it's just a game. You just play the insurance game, so. Okay, so, I just had like a few questions. I still don't really have access for those at home to do, the groups and all of those fun things, so we're just gonna make it work again. But if you can definitely pipe in anytime from home, but I was just curious, and it just kind of show of hands, so if those at home wanna just type in the chat, if any of you are like really passionate about the endocrine system or hematology, or if you have like work stuff, so if you guys can kind of show hands, anybody like dig endo or hematology or whatever study?
Endo, just because I have a type 1 daughter.
Okay. Totally.
Not hematology so much.
And no one is responding from home, so I'm gonna assume you guys are like, okay, Kayla likes endo. Awesome. I wanted to make sure that you all, so I think what I'm gonna do with the PowerPoints, I'm gonna leave it up during class and then until tomorrow morning, but because these aren't like my slides, because this isn't necessarily gonna be the class that I teach forever and always, I'm probably gonna pull them down just out of respect for the instructors who did these slides. So I want you to have them tonight so that way they're in front of you, so you can see them well, but then I will pull them down. So if you want, these links are all the ones that are in the student area where you could find everything, but I just kind of put them together to make it a little easier. So these are the ones that were specific to this section, so you can go to. So it's a bit death by PowerPoint tonight, so I apologize. These sections are just so beast-like. So we're gonna go through the PowerPoints. I do have some breaks where we can kind of break it up a little bit with some questions. And there are a couple of group activities, so we'll do that as well. But I'm kind of gonna just move through the PowerPoints because these are sections that you do need to know a decent amount about both of these because they impact the entire system. Endocrine is like every part of the body, right, is impacted by the hormones, the circulating hormones, and obviously our blood. So red blood cells, erythrocytes, are produced in the bone marrow. Their lifespan is about 120 days, and their primary function is gas transport. Immature version has a nucleus and is called a reticulocyte. And again, you guys have access to these, so if there's anything specific that you're like, ooh, I really like the information on that slide, make sure that you grab it. So interpreting RBC count, these are kind of normal values for women, normal values for men. I will say that while they say the normal values for men and women, that's not the way, and you guys are all nurses, that's not the way it's listed. I mean, you see values, it's just like the values. So I think it's really important to remember that female values are not the same as male values. So if you see values for a patient that are constantly like out of range, but barely, it's just that person. It doesn't need like crazy workup or anything like that. So just always keep that in mind. So anemia is an abnormal decrease in red blood cell count. It either means decreased production, increased destruction, or blood loss.
Sorry, did you, where's that plus sign?
Oh yes, because it's like super tiny.
I mean, because I'm having a hard time getting on the Wi-Fi.
Me too.
Do you guys have the password?
It's saying Google Drive won't let us because it says attackers might still try to steal.
Oh, so it's not gonna let you
It's
in.
not letting me, yeah.
No, I don't think they're able to, but I'm not able to.
Were you able to download it?
Yeah.
Are you able to do it?
Well,
They
no,
have
I
that.
didn't.
I think they have that.
This is,
Oh, I got mine.
But Linda would have been happy with you because you don't have the MacBook.
I think that will still give you,
Okay.
I don't know if I can go that.
Is
that okay?
Is yours letting you click on the link to the video?
Let me look up that. Yeah, but if you try to scan it,
Oh, there you
like a different one, yeah, they might let you.
What do you do?
Make a difference.
How's that?
Yeah, yes, that's better.
A lot bigger? Okay.
Because Google won't let me do anything here at school.
Oh, okay.
But I can do it on my like Internet Explorer or whatever. Safari.
Is that working? And you have the password? You're on
Yeah,
it?
I am online, but it's saying
It's a privacy error.
Just weird that some people can,
on Google
Get it.
or on
Google, but I could try it. Safari.
okay, you guys try that and see if that works. Helps. So interpreting red blood cell count, increased red blood cell is polycythemia. So these are like things that are important, like to know for boards, because these are questions that are definitely going to be asked. There's primary, secondary, and living at altitude. When I lived in New Mexico, we were at about 44,000, 4,200, and that was enough. Definitely saw some increase in blood values. So again, be mindful of where you live and think about that because they could be a little elevated, particularly if someone is also a smoker and also has lung disease. And so they might hang at the upper end, and you just want to monitor what their normal is. And then relative polycythemia, like in a setting of dehydration. Red blood cell indices, there's the MCV and the MCHC. So, this is really understanding these to minutia is really gonna depend what you work in. Because if you're in family practice, you're not gonna see a lot of severe abnormalities, but if you're in the emergency room or you're in urgent care, probably, because people are coming to you sick all of the time. So really knowing like what you're looking at when you're looking at the CBC. So volume occupied by a single red blood cell, increase in MCV is known as macrocytic, decrease is known as microcytic. These are all things that I think even as an RN, we kind of get a basic overview of. Red blood cell indices, normocytic anemias, which are like blood loss, hemolytic anemia, microcytic anemias, iron deficiency. I'll tell you, you're gonna see iron deficiency like all day long, particularly if you work with menstruating women, like all the time. A lot of people eat a varied diet, and so if you have people that don't eat any red meat, they're going to be low in iron and B12. That is where, I don't care how many vegetables you eat, I don't care how many beans you eat, it doesn't matter, like you're going to be low. So I would say that one of the things that I found in practice that has made me a really good provider and people keep coming back to me is that I check B12 and ferritin and iron. And so it's an easy fix, but people come to you and they're like exhausted and tired. You supplement them with things that are over the counter and they feel better, and that's all you do. It's crazy. And they're like, oh my God, I love you, you're so amazing. You're like, I'm really not. Like I just checked something that should be checked. So always think about that. By the time someone gets to where they're iron deficient or B12 deficient, by the time it shows up in their red blood cell count, that's like, they're really bad. So you want to check it before it's even showing up in their hemoglobin and hematocrit, because by the time it gets there, it's going to take you months to get them back to normal. I mean, again, unless they're like, it's super severe and they need like IV management. I don't know what that was. So the hematocrit, this is again, just trying to give you a picture of what this looks like in your brain if that's the way that you learn, is through more graphs. And then it again shows the differences in percentages between males and females. So there's the rule of 3. It applies to normal cytic, normal chromic erythrocytes only. It's useful to detect laboratory errors in measuring the hemoglobin, hematocrit, RBC count. 3 times the RBC count should be the hemoglobin, 3 times the hemoglobin should be the hematocrit. Again, if you're doing a lot with blood disorders, you might do that. Otherwise, I never did this in family practice. It wasn't something that I had to do. So I also don't know that that would necessarily be something that would be on boards. And then this is just, again, drawing out the rule of 3 and then helping you to figure out how you would calculate that. So you'll have that to go back to. And then interpretation of the red blood cells for a standard CBC with the total red blood cell count, the hemoglobin, the hematocrit, the MCV, and the MCHC. So I don't know what your guys' thoughts are on this. Like, would this be somebody that you would do something for? So these are the normals, and these are the patient that came in. So is this somebody that you would be like, we kind of need to do something for you?
I have a question. The MCV and then the MCHC.
Yes.
So those two, I know that if you have thalassemia or if you have sickle cell anemia, it has, I don't remember how it works. I think one has to be down, the other one has to be
Yeah, so they're going to be impacted. I don't remember exactly which one is impacted, but that's actually a really good point. So that's the other way that you can use a complete blood count, is to diagnose things like that, where you have something that is like the hematocrit and the hemoglobin might look normal, but then the rest of the indices are outside of normal. Yeah. And then you need to figure out, like, this is bizarre, because all of these things should be within a normal range. And I think they're in some of these slides, I think we get into sickle cell too. So
sickle cell and thalassemia and another anemic. So, because I know that's how the doctor diagnoses the thalassemia, my thalassemia, because everybody said it was normal because my hemoglobin was okay. But as soon as she saw that, she said, no, you have thalassemia.
Yeah.
So,
Was the NCH? Cause I just read something earlier.
And we'll go through more of the thalassemia conditions too. So again, like for boards, just keep it simple, Don't go into the weeds of all of these things because it's hard to like keep out what your experience has been too. We kind of talked about that earlier. Like whatever area of focus like if I took the boards right now, I would probably flunk the endocrine part because I love it so much. I would just like interpret and be like, that's wrong. So just be careful of doing that. So what does anybody have a thought about like this patient? What are you thinking? Anybody at home too? Oh, we have more people join. Oh. Okay, so Andrea, like, you can type or get on, but can you talk to us about what about the numbers are making you think that, and then also what you might do? No, and then how about the hematocrit and the hemoglobin? Okay, so here's a good example. Doesn't matter. Take your hospital brain out of your head, right? So your normals that you see in practice doesn't matter. Doesn't matter. So on this, your interpretation is that it's low, right? Okay. Yeah, I agree. I mean, so this is somebody that, well, what would you guys do? Like, let's say you're in family practice, this patient comes in, these are their values.
maybe some tablet.
Okay, so you'd automatically give them iron. Is there any other lab that you would check?
Yeah, you have to check for other things because you don't want to give them some iron if they have other underlying, they have renal failure, if they have thalassemia, I cannot keep that much iron at me, so therefore I cannot start me with this.
Right. So, and somebody, Susan put on here ferritin and iron. And ferritin is the one that's really important to check because ferritin will start to decline before iron does. So if you can catch it when ferritin's starting to decline, then you've like really saved the patient from having to go through. This patient probably doesn't feel that good. They're probably fine, they're functioning, they're out in the world, it's fine. But yes, so you know, if this were my patient, all I had was a CBC, I'd want to get like a metabolic panel, I want to check iron, I want to check B12, I want to check ferritin. So just kind of thinking about the other things that you might do. And then, you know, assuming it's iron, then obviously like supplementation. Okay, so reticulocyte count, those are normal values. It's helpful to identify the cause of anemia. And increase indicates anemia is due to blood loss, decrease indicates that anemia is due to bone marrow disease. So this is just kind of a snapshot of the amount of Americans that have anemia. I would actually probably say that it's higher for women, just anecdotally of having worked with women's health for so long. I have so many patients that are anemic and they have, again, mild anemia. They can function in the world, but they're just chronically a little tired all the time. So our body manages to supplement what we need to survive, but not necessarily to thrive. And we want our patients to thrive. So I might save this one, but it's one that you might want to keep, and we might go back to it. We'll kind of see how long. I just want to make sure we get through the PowerPoint slides as well. But if you wanted to do this on your own, this would be a good one for studying. So kind of maybe take a snapshot of this one and keep it in your back pocket to go through the exercise to study. Again, we might go back through it, but so Hi, Carla. Welcome. Anemias, there's microcytic, macrocytic, anemia of acute blood loss, aplastic anemia, polycythemia, leukopenia, and thrombocytopenia. Iron deficiency, we kind of talked about that, hemolytic, the blood loss, malignancies, infection, inflammation, aluminum toxicity. I don't know that I've ever diagnosed that specifically, but I think that this slide is important because there is so much that you can tell and diagnose off of just a complete blood count. And not necessarily diagnose, but there's so much that you can then move forward with. It gives you a really good idea of how a system is functioning. So when you get into practice, and let's say you're in a family practice, and let's say you're seeing 24 to 28 patients a day, it's really easy to just glance over the CBC and be like, you're good, moving on. You have two things that are a little outside of normal, but we're just gonna move on. And if someone's asymptomatic, that's fine. Your patient's coming to you, they're totally fine, they're completely healthy, you're just doing annual blood work. But if someone is giving you symptoms and there's something even just a little off on their CBC, think about where that might lead you and what it might mean, and dig a little deeper than just okay, you're a little tired, you're a mom, you're stressed out, you're fine. Not necessarily. People with kids aren't necessarily always tired. There may be something else going on. I mean, we are, but dig a little deeper if they're concerned about it. So this again is pathways. I think that pathways when you first go into practice especially are really important, particularly if you're in a patient population where if you're in family practice and you're working in a population where there are a lot of really sick individuals who don't have a lot of resources, these pathways are really nice because you can just kind of open up the pathway and be okay, this was low, I'm gonna go down this pathway to see what it might be. So tables like this, and this is a really basic one, but you'll be able to find things on your phone now. There are a lot of apps where you can just pull it up and be this is what's happening on my CBC, what's going on. So here's what the question that was asked earlier. It's the MCV low, that's thalassemia or iron deficiency. Normal, if the MCV is normal, then potentially it might be one of the renal disease, chronic disease, because the body's compensating. So just check that one out. Again, this just kind of goes a little bit deeper with what does it mean if the MCV is low and following this pathway, because it can mean so many things. But I like this slide because then if it's really significant, you're gonna send it to a pathologist to have them look at the actual blood droplet under the microscope. This isn't something that you're necessarily gonna see on just your standard CBC. So then doing the further diagnostic testing, and these are the things that you might want to check. So I like this slide because you don't just stop, right? You keep digging. Normal MCV again, kind of just bringing you down the pathway, and then high MCV. So I think these are really good. So these might be helpful as you guys study, just kind of knowing, okay, this is what this might mean, and these are the tests that I might do. And those are board-like questions. What might you do? This patient comes in, this is what the CBC looks like, what additional testing might you order? And then they're gonna give you 4 answers that all seem right, but they're not, because there's one that's righter. So just knowing okay, I remember looking at this slide and I wrote it out, and that is probably the best selection of the questions or of the answers. Iron deficiency anemia, there's the definition. Again, kind of incidence of in women and men. I again would say that that's a lot higher, and I think a lot of it is related to gut dysfunction. And so if you have a woman who's menstruating, she's got horrible gut dysfunction and she doesn't eat any red meat, she's going to be anemic. If that patient comes into you, I don't even care what her CBC is, you say you need to take a multivitamin with iron. You at the very minimum, take a multivitamin with iron. Iron's tricky because if any of you have taken iron, actually been prescribed iron, it makes most of us feel horrible because it causes constipation, stomach upset. So just keep that in mind, and that's why it's so important for us to get on top of it when their ferritin is low, because then a multivitamin with iron is gonna be fine. That's all they need. They haven't had blood deficiency long enough in order to require more. Blood loss is gonna be one that, that again depends on the setting that you're working at. I mean, if you're in an urgent care or acute care setting, obviously like blood loss is gonna be something that you see a lot, not so much primary care setting. I don't know, you never know. Some people come to their primary for everything, but you really don't want them to come to you if they're like bleeding out or something. So main causes of anemia, again, iron deficiency and chronic disease are kind of like the two top. The key functions of iron, transport and storage. So enzymes involved in energy production and cell diffusion, and then a role in the function of the immune and central nervous system. So that's why hematology is so important, right? It's like important just for living. Okay, this is kind of what I was talking about. I have this discussion with patients all of the time because I work with a variety of people, and the whole vegan, vegetarian, animal, like, and I'm fine. I don't care how my patients eat as long as they're supplementing. But there's a lot of misinformation about like spinach, particularly. Like I have patients come in all the time and they're like, but I eat spinach. I'm like, that's fabulous. Keep eating spinach and have some meat, like have some red meat. Right? So even a small amount of red meat, it doesn't have to be a lot. And if they don't want to do that, they really have to take iron and B12. Like they have to if they want to optimize how they feel. You can definitely prescribe iron. You can, B12 is a little trickier. You can prescribe injections. That's oftentimes covered. If you have proven that they are B12 deficient, then they can do either like once weekly or once monthly injections. The B12 is usually sufficient. But you have to be asking these questions. You have to be asking people what they eat because they won't tell you. And you have to ask them specifically, are you eating red meat? And this is why. So I like this slide a lot. So types of anemia, heme iron, and that again is like the one that we're most easily ready to absorb into our system and that actually help us from becoming anemic. From animal, and then inorganic iron supplemental. I'm sure that you guys all have heard that you need to take vitamin C with iron. It actually reduces issues with constipation because the vitamin C helps to absorb the iron supplementation. So most iron supplements actually include vitamin C automatically. But just make sure that if that's not the case and you're prescribing the iron, make sure that your patients also pick up vitamin C. And we need vitamin C anyway, so I just tell them to take vitamin C every time you take the iron. You're not gonna like overdose on vitamin C. So, and then the average adult stores are 1,000 to 3,000 milligrams of iron. About 1 milligram of iron is lost every day. And this is what I was talking about with your menstruating females. Menstruation increase is lost to about 2 milligrams per day, so that's like double. Like the fact that we just don't tell women to take a multivitamin with iron. I mean, if you're having a period, you should take it. It doesn't matter whether it's heavy. And then you have women who have very heavy menstrual cycles on top of it, and I would say that it's more than 2 milligrams. Pregnancy use is about 3 to 4 milligrams per day. Women store half as much iron as men. I mean, we're just like we have no chance. And heme iron is from anything with blood. Non-heme is plant derived. The only other thing that I would add that I want you all to remember is that a woman who is no longer menstruating, so a woman who is postmenopausal, should not be on iron. If she's iron deficient, where do you check? Like what? Any thoughts? What your thoughts are? So you have a woman come in, she's 62.
Liver?
Maybe.
Bleeding.
Yeah, where's she bleeding from?
GI, right?
GI, right? So what's like the easiest test that you can do?
Stool call.
Yeah, right? So you can do a fecal occult if you have it in practice, or she's probably due for her colonoscopy that she didn't want to do because they're horrible. And so you encourage her like, hey, you're losing blood from somewhere and you're not having your period. We need to figure out where this blood loss is coming from. So just always think about that with women who are past menopause, haven't had a menstrual cycle in a year, they should not have a reduction in hemoglobin or hematocrit, and they should not be deficient in iron because they've had no blood loss for a year in that way. So just keep that in it's not on the slides. It's my women's health brain. And then iron metabolism. So this kind of gets into the nitty gritty of like, how do we absorb iron? And you can see like your daily diet and just the entire intestinal system. We have so much gut dysfunction that it's very challenging for the body. It's very challenging for the body to, our gut has so much work and so much it needs to do in order to absorb and, metabolize the food that we're eating, and we're not very good at it. So I know that you'll hear from a lot of providers, we shouldn't need to supplement. You shouldn't need to supplement. Yeah, that's great. In this ideal fantasy land that we live in, you don't need supplements, but we don't live in that world. So just always thinking outside of the box of like, okay, great, I wish this patient ate more of whatever, but they're not, so we're gonna have to give them their nutrients in another way. 3 stages, mildly lowered iron stores, which we talked about. Again, checking ferritin first. No clinical effects. Iron depletion, where the ferritin is less than 15. And then iron deficiency anemia. And then, supplementing once it gets to that point. These are symptoms. By the time they're getting these types of symptoms, they are very deficient. So try to get them at like, I'm a little tired. That's where you want to try to navigate. Not necessarily if you're in the hospital setting or in an acute care setting, but if you're thinking about going into clinic setting, try to get them earlier than these symptoms. But I would still know these symptoms because that's potentially board related. So the skin, angular chelosis, burning tongue, glossitis. I will say that the cracks in your mouth with the angular chelosis, that happens pretty quickly, so that's kind of an indicator. So that's a good time. There are other conditions that cause that, and it could be from a fungal infection. Like there are other things that cause that. But if you see that in a patient, think about running their iron and ferritin, and then hair loss, right? Hair loss was one that happened a lot post-COVID. So I was checking a lot of iron and ferritin, and they were fine. It was really just a post-COVID effect. And then diagnostic, low H&H, low MCV, low ferritin, low iron, yada, yada. So blood in the stool potentially. Stool's one that if somebody is, colon cancer is missed a lot, and it's missed a lot in people who are in their 30s and 40s, so don't miss it. Like if you can't figure out where someone's losing blood, think GI right away, like fast. Differential microcytic anemia, iron deficiency, thalassemias, hemoglobinopathies, anemia of chronic disease, familial conditions, miscellaneous stuff. Megaloblastic anemia, vitamin deficiencies, folic acid, more in pregnancy, and then really pernicious anemia, B12. I would say that if someone's not supplementing B12, so I like my patients to have a B12 between 800 and 1,000. I find that's when they feel the best. And I would say like the patients that aren't supplementing for the most part are hanging out around 300 to 500. That's bad. And again, I think it's because we just don't absorb very well. And even those people that eat red meat, they don't tend to eat red meat because it's expensive. Good red meat is really expensive, and I don't really want someone to eat meat that's like full of antibiotics and all the other crud that we put into our animals. So supplementation is great. B12 supplements are awesome, but anybody who's not getting sufficient red meat, have them take a B12. And B12 is great too because you can't do the injections. You can do sublingual. I recommend sublingual. I find that the oral that you swallow doesn't absorb nearly as well, and the sublingual is super easy. So always consider those things too. Low dietary sources, like I just talked about, disruption in DNA synthesis, and then ineffective erythropoiesis. B12 deficiency, these are, reasons. You'll you'll see tapeworm if somebody travels outside of the United States, but they're gonna have lots of symptoms. Well, we talked about that, we talked about that last week, so. And then folate deficiency, again, dietary deficiency, lack of absorption, and then increased folate consumption. Drugs that cause deficiencies. So these may be things that are on boards, I'm not sure. The thing that sticks out to me more than anything is oral contraceptives. Oral contraceptives cause lots of bad things in our body. So again, a lot of these young women aren't getting the CBC drawn because they're in their 20s, they're like teens or 20s. Like, why would we check a CBC? They're fine, they're functioning, they're a little tired, whatever. Think about doing that. Like if they're on the OCPs, they seem a little tired, like check a CBC, check the ferritin and iron. They're pretty well covered by insurance, those 3 tests are, so. And then obviously like some of these other medications aren't ones that you'll see as readily in practice. Methotrexate you'll see a lot because it's a first line for rheumatoid arthritis. So I would really hope that if you're seeing a patient with RA, you're checking these things anyways. Metformin is like a big one that you're gonna have almost all patients on because in order to get other medications covered with type 2 diabetes, you have to be on metformin. I mean, you just have to be, like you can't get it covered. You have to at least try it. And if you have massive side effects and you're off it, it's fine, but you have to at least try the use of metformin. And metformin affects, our gut function. So really all of those patients should be on a multivitamin with iron. A multivitamin kind of covers all of your bases and you can prescribe it. It's not the best brand, it's not my favorite, but if that's what you can get to patients, it's better than not having anything. So symptoms, I mean, again, like fatigue is very common. I would say the thing that I've seen more often with B12 deficiency in patients over the age of 65 is that mental clouding, like where they're just like not themselves and you check their B12 and it's like less than 200, like it's not even detectable. So try not to, if they're your patients, sometimes they'll just come to you that way, but if they're your patients, just think about that. I know we talked about UTI last week, so think about B12 too in those patients. So diagnostic would be the CBC, LDH and indirect bilate, serum B12, Schilling's, folate, pregnancy test. Obviously you're not going straight to bone marrow, like at the point that they need bone marrow. I mean, if you're working in oncology, that's great, but otherwise you're like, bye-bye, like you need like some other tests. And then B12 deficiency, these are kind of just the lab findings that you would see. And then, again, kind of another table to give you like, okay, this happens, then what do I do? Okay, like, here's a good example. You measure their B12, their folic acid's low, you treat them with folic acid, recheck their levels, they're good. That's the circle we like to be in. It's like, they needed that, you did this, great. But again, these tables are really a nice place for you to go to study, kind of like writing them out. Like methylmalonic acid and homocysteine, these get complicated pretty quickly. Homocysteine is something that you'll hear more and more, like patients will come in and talk about homocysteine. It's definitely something that's getting more attention for people in the kind of biohacking, wanting to optimize their health and the impact that has on inflammation in our body. Not that that's anything that you guys need to know for this, but just something to consider. So as homocysteine goes up, then all of these end up with your essential amino acids decreasing. So all of the B12 is very similar to what I was talking about with D and the fact that it has all of these cascading like downstream effects. So it's really, really important because these are the reasons that someone feels really crappy if they don't have B12, because it's not a hormone, but it's so essential to our system and to our bodies that it acts like a hormone, and we become very symptomatic without it. So if you don't have B12 or sufficient B12, these are the other factors that might lead you into thinking that there isn't sufficient B12. And again, homocysteine level would be one of those factors. Acute blood loss. So these are the ways that you might notice that or diagnose acute blood loss. Again, I think these slides are kind of interesting because I mean, hopefully acute blood loss, you'd have an idea, they fell, there was an injury. I mean, maybe it's internal, but there was an event of some type. These might be the symptoms, and due to an acute hemorrhage or hemolysis. Symptoms, again, neurological, cardiovascular, respiratory, genitourinary. I mean, that's why hematology is such a beast of a topic, because if you don't have the blood that we need in our system, then all of the systems start to break down. Sites of blood loss, again, definitely if, a lot of the things that will come to you are going to be more chronic disease conditions that have been going on, but sometimes a chronic disease condition can then lead to an acute situation. So thinking about that as well, and then massive hemorrhages. I can't remember how many people work in that setting, ED, acute care. Does anybody from homes? I don't know if anybody works in that setting. But if you work in that setting, then you're probably going to feel pretty comfortable with all of this because you've seen it. That's usually where patients end up going, is in an emergency room setting.
That was my primary background for a long time.
So, I mean, this stuff, acute blood loss is something that's hopefully where the patient is going again. And then, so a traumatic injury, a sickle cell anemia, thalassemias that have been undiagnosed, ruptured aneurysms, platelet disorders. So there are a lot of different factors. Willebrand factor, von Willebrand is something that oftentimes is kind of diagnosed in pregnancy, and it was undiagnosed. A lot of blood conditions, if they've been able to just kind of lay low and the patient hasn't developed a lot of symptoms in women, if they become pregnant and during pregnancy or during delivery is when it's oh God, or an inability to become pregnant, right? So all of those things can lead you down the right road. Workup, the CBC, reticulocyte count, peripheral smear, folate, B12, iron, thyroid, hemoglobin, chest x-ray, abdominal ultrasound, all of those things. And again, this really just depends on your setting where you're working. And then the rest of the CBC is going to include your white blood cells, your segs and bands, and then your platelet count. So, and then here's some ranges for an adult. And then I really like this picture. It's pretty nice in terms of what does it mean when your neutrophils are elevated or outside of normal? What does an eosinophil mean? What does a basophil mean? What does the lymphocytes mean? What does the monocytes mean? I can't remember. Did we go over this last week a little bit too? I can't remember. No, not really. So I think we did talk about eosinophils or something. We're talking about allergies. I don't remember. Okay, I'm unless I've gone crazy. So eosinophils are going to be ones that you'll look for if there's an acute inflammatory response. We talked about parasites, neutrophils, possibly bacteria. That's the one that you'll see outside of normal range for that. Basophils, more like an histamine inflammatory response. Lymphocytes, they're the regulators of the T cells. So lymphocytes can be outside of normal for a number of different conditions. So I wouldn't say that I've used that, the lymphocyte count as a rule in or rule out of anything. generally when one of these are off, there's gonna probably be a couple of them that are a little bit off when you're looking at your CBC. And it's hard, obviously, to make a diagnosis off of, I mean, you sort of can, but if the white blood cell count is a little bit elevated, the eosinophil count is a little bit elevated, the patient is in front of you sneezing and hacking, then yes, but I don't know that you needed the CBC to tell you it was allergies, if that makes sense. Like mild things, you don't necessarily need the CBC to like tell you. It's helpful if maybe you're thinking, oh, this might be pneumonia or this might be a bacterial conditions, because then you see an elevation in neutrophil, or a change in the neutrophil count. So here's like a actual like CBC with differential. You can see that everything from the white blood cell count looks fine. MCD is high, MCH is high, and then red blood cell count is low. Hemoglobin and hematocrit are completely fine. So this would be something that would require additional attention, right? Because something's going on with this patient. And depending on how much you review CBCs, you might be able to just look at this and just know, but for most clinicians, they're gonna have to like review it because it's not one that you see all of the time, and that's totally okay. And that's why you need your resources. Aplastic anemia, bone marrow failure syndrome characterized by peripheral pancytopenia, pancytopenia, and marrow hypoplasia. It's very rare. I don't know that they would have this on your boards. Like to me, everything else we've talked about is like so much more important than an aplastic anemia situation. Again, unless you work in hematology oncology, then yeah, that's going to be what you focus on. So these are just definitions. I would review these again. I don't know. I mean, I guess if you guys are doing studies and this seems to come up a lot on your board questions, dig into it a little bit more. Otherwise, I would just have like an overview knowledge of what are on these slides and what are in the review textbook and review. Etiology of aplastic anemia, the drugs that can cause concerns, toxins, malignancy, inherited disorders, pregnancy, infections. So there can be a number of factors. And then clinical presentations, fatigue, shortness of breath, petechiae. Anytime you see petechiae, bad. Like it's bad. Like you have to do a lot more about this condition. Recurrent bacterial infections, and then physical exam, and no splenomegaly. And then diagnosis. Again, this is why I'm like, you're moving this patient along because they need a bone marrow biopsy. So unless you're working in oncology. And then history of exposures, HIV is something to consider, high mortality rate. Polycythemia, abnormal multi-potential hematopoietic stem cells, excess production of normal erythrocytes, overproduction of leukocytes and platelets, and then increased production of red blood cells. So kind of looks sludgy, like everything is just like under the slide of things, just kind of like on top of each other. That's not the way you want things to look. You're gonna find that they have an elevated hematocrit. You might be dizzy, weak, sweating. Risk for MIs, DVTs, PEs. This is one that you also obviously want to catch as early as you possibly can. Like not a good condition to. In my work now, like we treat a lot of men with testosterone, and testosterone tends to increase the hemoglobin and the hematocrit. So something that we check a lot, and then those patients, just like any patients with these conditions, if they donate blood, it's a great way to keep your levels where they need to be and treat it so it doesn't turn into something more significant. And like all the dudes in their 40s and 50s are on testosterone now. So even if you don't do that work, you're gonna have those patients. And then primaries caused by intrinsic hyperproliferation of the hematopoietic stem cells independent of erythropoietin stimulation. And then secondary is due to elevated levels of erythropoietin that induce that proliferation. again, like I love these tables as a new practitioner that's just like out. These tables will save you every time because you can follow a pathway. That's the nice thing about the human body is that even though we're learning more and more about it, these standard pathways, they stay the same. Like the human body functions similarly all of the time. So considering using these tables. It's a great thing. So, I'm going to pull up. I told my husband we get one break and he was like, that's unacceptable. He was not a fan of one break. It's like 4 hours of one break. So I'd kind of like to switch over to some questions because I have some questions so that way we can do some group work. And I'm sorry for the people at home because you don't have each other. And I don't know, I'll continue to hunt down someone who can help me with breakout groups because I still don't have the power to do that. But if Andrea, Ashley, and Danny want to work on the question of how do you differentiate anemia from B12 deficiency? And what is the workup and treatment for both? That would be awesome. I'm gonna put this in the chat so you guys, it's okay if you don't remember.
Able to get this PowerPoint pulled up. I tried everything. Does someone have a pull up?
And then if Elizabeth, I can't remember which group I put you in. I think if I put you in the first one, then don't worry about it. But otherwise, Elizabeth, Carla, Kayla, and Susan, if you can work on this question, which is a female patient, hemoglobin is 7 and her hematocrit is 22. What signs and symptoms would you expect her to present? And I'll put this in the chat. So that's for group 2. And then in here, if maybe, I think we can do groups of 2. I think we'll do groups of 2. We'll do 2 groups of 2 and 1 group of 3. How's that? Does that work okay? Yeah, okay. So if you guys can work on, do you have the PowerPoint? Well, you do, this isn't in the PowerPoint though. So a patient presents with fatigue. He's anemic. His MCV and MCHC are low. What labs would you want to do additionally? And then what would you run to find the source of the blood loss? Did you get that? Okay. And then, you guys okay working together? Is that okay? Okay. So a patient presents with left upper quadrant mass. On exam, spleen is palpable and it's really low. What lab test would you order?
So left upper quadrant mass and spleen is low.
Yeah, like spins like all the way down to the umbilicus. And then for the 3 of you, a patient complains of fatigue, his white blood cell count is almost 100,000. What additional testing would you want to do? And then we'll just, like 10 minutes. You might not even need that much time, so if everybody's done before that, that's fine.
So she said it's not
There's no way you can put department because it's not yours, right? Like you can't put it in Blackboard, can you? That's what our old teachers used to do.
It's in Blackboard, I'm sharing the screen, like I'm sharing the slides.
You have to unlock it for us, like that's what Eric used to do, and I don't know how to tell you to do that, but.
I mean, like you don't see it on here.
You don't either, right? So like if you open it, she's the only one who's gonna look. She's in there's only one person who's gonna open it.
Sorry, okay, well,
Like from the Google Drive, I tried can't, we're going too fast for me to like, you know, and I'd like to screenshot or like.
Oh, it does say you can't.
Yeah, I tried everything. I tried Safari, I tried Edge, I tried everything. I think it has to go through Blackboard. I mean, I'm sure.
It might be the firewall here.
Yeah, that is what it is.
So I think
Because
there's no lock on this, it says that like sharing the files. So there's no, like, I would unlock it, but there's no, it doesn't. So if he uploaded it to Blackboard, that's different. But I can ask him, I mean, I don't know with him right now, but, because the other option would be that I'm uploading it to that Google Drive, like on Thursday mornings, so if you wanna download it.
That's probably what she did. Just download it. I wonder if that's what she did. She's the only one who can get it to open.
It's the firewall, because I just got off of the Wi-Fi here and just hooked up to like the phone, and it works. It's the firewall. So you have to open it.
Or you can hotspot. I have.
Oh, yeah. I just want, I guess that's what I do. That's what Well, set up your own hotspot.
Yeah, like, it used to be that under learning activities, the PowerPoint would be there, you know what I mean, like the.
And I would do that, but they're not my PowerPoint.
I get that, that's.
Like if they were my PowerPoint, I absolutely would do that, but I just don't wanna, you know, and he's great, he's not, like.
Yeah, I get that. Okay, white blood cell, fatigue, male. Towards male. Yes.
I don't know.
Stop it.
Okay, we will come back together, so wherever you are, that's perfect. So for group one, those questions, who in that group would like to respond? Andrea, Ashley, Danny. Okay. That's what I think. That's great. That's great. Yeah, thank you. Danny, did you have anything you wanted to add? I see your microphone. It's okay if you don't. No? Okay. Yes, I agree with all of those things that you said. I think that not necessarily only, oh, Danny has another link for us. I love Danny's links. Let's see. So Danny links to the NIH, and NIH has a really nice, I really like their website actually, it's a really good tool. And it's a whole section on vitamin B12 deficiency anemia and options and how you can treat. So I'll, just like last week, I'll make sure to link that and I'll send it to you guys in a message. So that way you have that. Thank you, Danny. And then the only thing that I would say is that I disagree with normals all the time. I would not wait till someone has a B12 of 200. In your textbooks will say that, so remember it, because if it's on boards, it's gonna be that value, but in practice, never wait until it's 200. Somebody feels really horrible by the time their B12 gets to 200. So yes, but thank you so much, that was perfect. Our next group, I think Carla, Kayla, Susan, we had some people drop off, but if one of you could respond to that second question. A female patient has a hemoglobin of 7 and her hematocrit is 22. What signs and symptoms would you expect her to present with? Hey, Betty.
I can tell you see it all the time.
See, that's stuff I see in it, that's stuff I saw in the ER a lot, so that one's.
Yeah, that was it's pretty straightforward. Okay. Oh, Susan. Oh, and Kayla, whoever. If you're speaking to us, Susan, we can't hear you. You can also type in the chat if you're having connection issues. So if one of you guys wants to type in the chat, you can do that too. So let's go to you guys. Do you wanna? I'm trying to get names though too, so it's Nor and Dorothy. Dorothy, okay.
So the question was about a patient comes in who's fatigued, who's anemic and has a low MCV and MCHC. What's the treatment and where's the bleeding coming from? It was very confusing to know where the bleeding is coming from, but given the low level of anemia and MCV and the MCHC, we said that the patient would have the thalassemia anemia. So the diagnostic test will be, since it's hereditary, we can do genetic testing, especially for the first type, the alpha globulin protein chain. We can also do a CBC test, the hemoglobin electrophoresis, and peripheral blood smear. And as far as treatment, blood transfusion, folic acid supplements, and to go to the extremes, bone marrow or stem cell transplants.
Yeah, and then, I mean, you know, so many of these blood conditions, you're right, it's hard because it's like, well, which one is it? Just based on such limited information, you really need a lot more information. But that's a great place to start, right? You have to start somewhere, and particularly if you're in primary practice, you have to start somewhere. You're like the first place. So you start and then you go down the path that the labs and the diagnostic and the imaging and all that is taking you.
Isn't thalassemia usually in the Jewish population?
I don't know if it's higher in Jewish.
Mediterranean.
Yeah, Mediterranean. Yeah.
Okay. I just thought there's something that kind of sits in Jewish, and I can't remember which one it isn't just, I don't know which one it is.
I'm trying to think. I know what you're talking about. It's in my brain, lodged in somewhere. I will find that because I know what you're talking about, and I'll message it to the group. It's like starts with a K. I'll find it.
Okay. And for some reason, that and that other thing, those two things are like seem
Connected in your brain.
I don't know why.
It's probably accurate. Usually when they're connected, it's accurate. Okay, next one is a patient presents with left upper quadrant mass. On exam, his spleen is palpable below his umbilicus. What laboratory test would you run?
We decided to first do a CT or an MRI to appreciate what's really going on and what the possible, if it's a mass or a spleen enlarged spleen.
That was right, you had it right.
And then we're gonna do like CBC with differentials and then CMP.
Just kind of like basic, let's start out, let's get liver enzymes, let's get an image. I think that's great. Yeah, it's a good place to start. And the final one is a patient complains of fatigue. His WBC is very elevated. What additional tests are necessary?
First thing we wanted was the CBC with diff to like get a better full picture.
Love it.
And you said over 100,000, so we were like, he's just gotta go to oncology, we're done.
So you guys just
No,
finished with him?
no.
See you later.
Janet has a good list of questions we need to ask him.
Okay.
It's fine. I mean, you could ask them a lot of questions like if they're stressed, smokers, obesity could be a factor. You could also look at like blood smears. You can send it to pathology or inflammatory markers like seborrhea and CRP.
Love it.
So obviously some sort of infection.
Yeah, it could be a lot of things.
Yeah, so I think like in practice, the tricky part is like nurse practitioners, we get dinged all the time for doing too many tests, which I think is ridiculous because I can't tell you how many patients I've diagnosed with something that was missed for years because people didn't want to do a stupid test. That was like not that big of a deal. So you just have to be really mindful of like not putting like everything in the kitchen sink into your, like someone comes up with an elevated white blood cell count and you are all of a sudden doing like an MRI and like craziness. So you want to like kind of start with those tests that are more basic and reasonable, dependent on the patient condition. Like if the patient is really suffering, you need to be a little more aggressive. And that's why patients love nurse practitioners, because we find things, because we're like, we'll order the tests and we'll listen to what they're experiencing. But you just have to be really mindful of not ordering like everything all at once. It's okay to go down a path or a couple of paths and then order the next thing and then the next right thing and then the next right thing rather than all of it at the same time. So it's just something to consider as you guys like move forward in practice. Yes, that's great. So I think what I'd like to do is let's just like spend a few minutes just kind of initiating endocrine, and then I do think that a break from 7:30 to 8. I feel like that worked okay. Is that okay with everybody? I know it makes the last bit a little bit longer, but endocrine is it's a lot. So as we get started, just the endocrine system, the exocrine glands are ducts, and the endocrine glands have no ducts. This is kind of an overall picture of the pituitary gland, the thyroid and parathyroid, the adrenal glands, the pancreas, and then the ovaries and the testes. So the endocrine glands secrete hormones which regulate various functions throughout the body. Hormones affect or influence all of the things, just like hematology. I think they're good, they're well grouped together because they really impact how everything about how our body functions. Reproduction, growth and development, cellular metabolism and energy, maintenance, like maintaining water, electrolyte balance, and then nutrient balance of blood. Chemistry of hormones, types of hormones, amino acid based hormones, which turn into peptides, and then steroid hormones, which are synthesized from cholesterol. One thing that I see a lot in women is that we've treated women like men for a really long time. So the use of cholesterol medications when a woman's cholesterol gets slightly elevated makes them feel horrible. So you'll find that women who are placed on statins tend to have, statins or any cholesterol medication tend to become more symptomatic with those medications. And it's because we have a lot of hormones and they all, like the whole cascade, all starts from cholesterol. So when you deplete a woman of her total cholesterol too abruptly, that can impact how she feels just hormonally all the way around. So just keep that in mind. I tend to be a lot more, again, the values are like the same and they really shouldn't be because a woman that is a PhD, like she studies women and there's a YouTube that she did that's called Women Are Not Small Men. And if you have time, like you can Google search it. And I love that because that is really how we've been treated in medicine. And we're not small men, so there should really be values like these are for women, these are for men. Like our total cholesterol can be a little bit higher and we can do just fine with that value. So just keep that in mind when you're in practice too. And the endocrine system has a lot to do with that, right? So hormone target cell specificity. Activation depends on blood levels of the hormone, the number of receptor sites, and the affinity of the hormone for the receptors. So this is why the endocrine system is like so flipping complicated, that it's not just like you can get a value and then if the receptor sites are off or there's one part of the endocrine system that isn't functioning optimally, then it can really leave somebody feeling very symptomatic. Hormone action, there's two major mechanisms of hormone action, second messenger systems and then direct gene activation. So increase, decrease, normal cellular process, and then hormone response dictated by target cell type. So this is, again, kind of depicting what that looks like. So you've got the endocrine gland cell, going through the blood, and then you have this target cell that then moves out and water-soluble hormone. This is first messenger. So the endocrine system gets really, really, really complicated really, really fast. So not that, again, you need to understand and know the nitty-gritty of things, but just have a basic idea of how these hormones work and then how the hormones impact how a person might feel that's presenting in front of you. And again, you've got the hormone, you've got the receptor molecule goes through, and then that plasma membrane. So you can imagine too, like in thyroid disease, that's what makes thyroid disease so complicated, because you have the stimulating hormone that then has to be metabolized, and you have to like turn it into an active form of thyroid through the gut. And if your gut is like, so then it's the GI system too, right? How well is your GI system functioning for you to even metabolize the hormones that are coming from your brain? The receptor binds the hormone, and then the hormone receptor complex activates a G protein, inactivated adenylate cyclase, and then again, like activated, and then the GTP turns in, the ATP moves into CAMP, and then other reactions. So this is like at a basic level, and it becomes even more complex. I don't know how in depth you all need to study this for boards. I wouldn't imagine that you have to know the minutia of how hormones, what the hormones do at the nuclear level. But if it's coming up a lot under board questions, then it may be something that they want you to know about more in depth. I would doubt it though, because it gets really complicated. Steroid hormones move into the cytoplasm and then into the nucleus. The complex binds to receptor sites on chromatin, activating mRNA and transcription. And then from the mRNA leaves the nucleus, the ribosomes translate mRNA into a new protein, and you're in the cytoplasm, through the cytoplasm. So control of hormone release, like how do we control how much hormone is released from our system? And obviously it all comes from our brain. There's a negative feedback system, inhibition. This is one of the things that makes the testing on thyroid hard, because when you have low thyroid function, your levels are high. When you have high thyroid function, your levels are low. And that's like the best example of how tricky the endocrine system is. Nervous system is modulated through the hypothalamus, and then the sympathetic nervous system, and then major endocrine organs. Again, we saw that nice picture, and so this is laid out in written form as well. So let's stop here, a few minutes over, so that way everybody can kind of take a break, stand up, take a breather, because then we have like a lot of slides to go through. And we might not get through all the slides, which is fine, because you'll all have them tonight. So, we just had some questions about the quiz, so I just wanted to make sure that everybody was on here.
Unless I was on headphones.
No. So there were some questions about the quiz itself. So I'm just getting in here to pull that up. And So you all have access to the questions and to the answers. So the other thing that, like I didn't hear from anybody this week, so I just wanna make sure that everybody knows, like, if you take the quiz, you have questions, you have concerns, it didn't go the way that you wanted to, like, don't hesitate to reach out to me. Because we can like go through it together, like, I mean, I'm here as a resource. I might not be able to reach out to you right away, because I do work really long clinic days. So, and it might have to be in the evening that I respond to you if that works for your schedule. If you work at nights, just let me know and we'll figure something out. I mean, even if it's on the weekend, that's fine, because we do have this weekend. So if that's something that's needed and that I can help with, just make sure that you try to get the quiz taken like before as soon as possible, because my long clinic days are Monday, Tuesday, Wednesday. Again, we can go over things at night, but it's just a little trickier because of my work schedule outside of doing this. So what I would say, just because we have so many slides to get through for endocrine, is that if you have questions about some of the things you got wrong, if you're okay just messaging me and saying like, hey, question, 5 and 7, what is going on? That answer didn't make sense to me. Then message me. And I didn't write these, so I might not have an answer for you. I might agree and be like, yeah, that was a really lame question. But we can at least go over it, and that way if there's something that you didn't understand, then we can look for resources together. So don't hesitate, and that's what I'm here for, okay? So for those questions, if you wanna message me, and then I can either send resources or let you know if I also think that maybe it could have been worded differently and it's not you, it might just be the question. It's hard to make questions, so they're not always gonna be good.
I was just like scared, I was like, oh my God, this is gonna be based on my grade, I don't wanna fail.
And what I will tell you is that Linda and I went through before class and put in the percentages of what things are worth percentage-wise for your overall grade. And I think those quizzes are, it's not a huge percentage. So I don't want you guys to feel like if you did bad on one quiz, like that's just it. It's not. Like you have plenty of opportunity with participation, just making sure you participate every week, and then there are multiple quizzes, and then you have the tests, and then you also have assignments. So they're all worth something. So don't feel like if one quiz didn't go well, then, that's just it. Okay. Any other questions? Any questions at home? Chat people. We're like losing people, not adding people. We're down to not very many people at home, but thank you for those of you that are here. Thanks, Susan. Thanks, Danny. So, okay. Glandular function. So this is kind of an overview of what all of the glands do. Thanks, Elizabeth. So, I'm not gonna go through this slide, but you need to know. These are things you will be asked over and over again. And the endocrine system, it's nice to start out with it earlier because it's gonna come up in other sections that we do. So it's not like this is the last time you're gonna hear about these glands or about the whole system. Common endocrine problems. I am 100% sure you all know somebody who has one of these conditions. So when you think about these conditions, again, it's just really important. Don't go down the rabbit hole of personal experience. Keep it at like what is in the PowerPoint slides, what's in your book, basic. You're a new nurse practitioner going into practice. What do you have to know? Okay. The hypothalamic pituitary axis, otherwise known as the HPA. So you've got the hypothalamic hormones coming from the anterior pituitary, releasing hormones and inhibiting hormones, and then the hypophyseal portal system, which bypasses normal vascular route. And then the hormones stored in the posterior pituitary are oxytocin and antidiuretic hormone, or ADH. This is, again, kind of a complex drawing of the hypothalamic endocrine control system. Again, I don't know that you need to know all of these. It is important to have a basic understanding of some of the things that you will see on lab, like an FSH, LH, TSH, And we'll dig into those in some of the other slides. Those are kind of the things that you would want to know. And then also that they're coming from the hypothalamus, kind of descending down and then directly stimulated by the glands, the parathyroid, the pancreas, and the thyroid. So the pituitary gland, the hormones are stored in the anterior pituitary. These are some conditions with growth hormone. And then we already, we talked a little bit about thyroid stimulating hormone, adrenocorticotropic hormone, ACTH. A lot of these hormones, like when you're in practice, you're just going to use the letters because some of the words are just really, really long. So not that you can't pronounce them, it's just way easier to say ACTH. And then the follicle stimulating hormone, luteinizing hormone, and prolactin. So there's just kind of a picture of the pituitary gland. There's what it looks like kind of dissected out, the posterior and the anterior. So anterior is the kind of darker, redder color, and then the posterior. So hypopituitarism, adults or children, adenoma in adults, and craniopharyngioma in children. Again, just some nice dissections, photos. Like I still wish that as part of the master's program, everybody had to go to a cadaver lab, because I do think that when you actually go in, I had an opportunity to do that. It was one course, but it was like one class, but it was so fascinating to actually look at a cadaver. And you remember the things a lot easier when you see what it looks like up close. And then, this just little pituitary little thing controls so much of what happens in our body. And then from the pituitary gland, got the breast, the adrenals, the thyroid, bone, ovary, testes, kidney, the uterus. This is a little blurry, so if you wanted to Google search that, you can definitely find a nice image that kind of plays it out, each of those. Anterior lobe function, secretion of TSH, ACTH, GH, FSH, LH, and prolactin. Posterior lobe, ADH, and oxytocin. And then from the pituitary gland again, here's just it's literally just another depiction of what all of those things link up to. I think however you need to write it out or draw it out, this is pretty basic, so it's really important. If you understand this, the rest of it's gonna make a lot of sense in terms of, okay, this came from the pituitary, it's this hormone that goes to the adrenal. It's this hormone that stimulates thyroid. So knowing what those hormones are responsible for will really help you in practice too. Hypopituitarism, pituitary adenomas. Pituitary adenomas are actually definitely a lot more common than I thought they would be when I went into practice. I diagnosed, most of them are totally benign. They're not an issue. They can just cause elevation in prolactin. So that's kind of like your first marker. Prolactin levels are again one of those that tend to be higher in women. So it's like a person's normal. So be mindful. That's one of the areas where when I first started in practice, like anyone who had an elevation, I sent them for an MRI because I didn't know. It was like a baby NP. And I'm like, oh, 3 by 5. Like you probably have an adenoma. So just don't do that. I didn't do it too many times, but when there's like a definite increase, like 20 is around the high end, but when you get like 30, 40, like you're probably looking at an adenoma. And again, most of them are benign. And so there's great medications that help to lower prolactin levels. Surgery, head injuries, radiation, again, all of those things impact the brain. Growth hormone deficiency, something that don't see as frequently, but in adults, less muscle strength, loss of exercise tolerance, social isolation, and then lower levels of libido. Gonadotropin deficiency can lead to dysmenorrhea or infertility, and then the adrenocorticotropic deficiency can lead to malaise and fatigue. So if you have too much pituitary, and that's like, again, those prolactinomas, so you can check prolactin and figure that out. amenorrhea, or illegal, I'm gonna forget how to, I think it's illegal amenorrhea. The period, like, so the cycles, they either have like no period or their periods are like just super chaotic all over the place. And then again, with the MRI, you always want to consider a mass, and you order MRI like pituitary protocol, so they're not like checking the entire brain, they're really checking and focusing on the pituitary. Headaches, visual disturbances, acromegaly, too much growth hormone, like super rare. I mean, if you see that, you know, that's just gonna be a patient that you're taking care of, they've already been diagnosed. That's not something that you're gonna diagnose unless maybe you're in pediatrics, with kiddos. Diabetes insipidus, that's funny, that picture's really funny. So neurogenic deficiency of the antidiuretic hormone, vasopressin, nephrogenic insensitivity of the kidneys to the effect of the antidiuretic hormone vasopressin, gestogenic deficiency also, and that occurs only during pregnancy, and then dipsogenic, abnormal thirst, excessive intake of water, other liquids. Causes, again, you know, you're thinking like big picture tumors, something's going on with the brain that's pretty massive. And then symptoms, you know, peeing all the time, drinking all the time, losing weight, dry mouth, fatigue. So, you know, I don't know how much of diabetes insipidus is going to be on your testing because we don't see it as often as a lot of the other forms of endocrine disorders, but just have like a basic knowledge of that. So endocrine A&P review, the hypothalamic pituitary axis, it forms a structural base for the neuroendocrine system, and it produces and releases several different hormones, which we've already discussed. The hypothalamus is divided into nuclei and is located at the base of the brain. It's connected to the pituitary via blood vessels and nerves, and it secretes ADH and oxytocin, which are stored in that posterior pituitary. We kind of went over that, so it's just kind of another overview. And then everything with the endocrine system is on a feedback system. So you've got negative feedback, where the response reverses the original stimulus. So an example of that would be like you have elevated blood sugars, which causes insulin production and release, and then the insulin reduces the blood sugar, and then insulin release stops. So it's like this whole cycle. So you can imagine in feedback loops, something can go wrong in a lot of different areas, and you have to figure out where's the abnormality, like what's causing the symptoms and the condition. And then the positive feedback, the original stimulus is amplified. It's usually found with self-perpetuating processes. So example, oxytocin's release stimulating contractions during labor. The contractions intensify until the baby's delivered. So it's just continuing that like stimulus, baby's born, levels drop. So kind of like an event has to happen to stop it. I think I really liked this picture. It's the same picture as one of the previous slides, but I just really like how it encapsulates like this is where it's all coming from, and then with the pictures and the overviews of the hormone itself, and then the gland that it's related to. Thyroid. I actually do want to do this exercise. I know we just came back from break, but I think it's nice for you all to be able to kind of work on these things and come up with these answers. And then there are slides. So if you have the PowerPoint slides, like the answers are on there. I mean, you can use those slides if you want to, however is best to learn. And I think group work is better. So if, I think we'll just have everybody do this. So everybody at home who's on, just go ahead and define what is T3, what is T4, what is TSH, what is TRH, what are they, where are they made, what is their function, what symptoms are experienced when they are too high, and what symptoms are experienced when they are too low. And you don't need to go into like crazy detail. Like I feel like we can do this in, definitely 10 minutes. And if everybody gets done, I don't think we need a full 20 minutes. So let's plan on doing it in 10. How about like 8:30? And if the people that are here, if you guys want to work together because you like working together, that's fine too. That'd be awesome.
Thank you. What I found is like everything is connected to each other. So T3 is the active form of thyroid hormones and is required by any cells to drive cellular metabolism. And T4 is the inactive form of T3. TSH produced in the anterior pituitary gland. And this one is the one that kind of talk with the thyroid to increase or decrease production of T4. The TRH is stimulate the secretion of the TSH. That's what I say is like everything is connected and in some way one talk to each other to produce or increase or decrease the production of the other. So the symptoms we have hypothyroidism is fatigue, constipation, muscle aches, and depression. And if we have high T3 and T4 or hyperthyroidism, is anxiety, difficult concentrating, fatigue also, diarrhea, goiter, hair loss, and hand tremor, and also heat intolerance. I think
Perfect.
this is what I found.
That's fabulous. Thank you, Elizabeth. Thanks for participating. That's great.
Thank you.
Anyone from here want to add to what she said? She gave a nice overview. Anything else that you found? Is interesting?
Asking periods if it's too much like T3 or T4.
Yep. So impacting menstruation. Anything else that you found that was interesting? It's really important to understand. Oh, God.
I just didn't know they all three came from three different places, like the one is pituitary, the one is hypothalamus, and the other one, like, that's all telling the thyroid what to do. I didn't realize.
Yeah, it's crazy.
Yeah.
Like a lot
It all has to work.
Yes. Like it's actually, I feel like one of the reasons I love the endocrine system is because I love the human body to begin with, and then you start to understand that and you're like, how do we walk? Like how do we wake up in the morning and like function?
Yeah.
That everything has to like connect to one another in order for us to feel good. And that's why I spend a lot of our lives maybe not feeling that great. Anyone at home want to add anything? I just want to give you guys a chance to, if you want to. Okay, so the thyroid gland, kind of talked about that, production of thyroid hormones. You've got thyroxine, which is T4, and triiodothyronine, which is T3. And I kind of mentioned that one of the issues is that if you can't convert T4 into T3, then you feel really cruddy and you have all of those symptoms. And the main medication for thyroid is T4. So if you can't convert T4 and we give medication that's T4, then sometimes it doesn't work, right? Like it's like we're giving more of the exact same thing that someone can't convert to T3, which T3 is the active one. I always think of T3 as like, I don't know, when I see pictures to remember things, and I just think of T3 as like the happy, like feeling good, and T4 is just kind of sitting there, not really doing a lot. It's like the lazy part of the thyroid, very important, but until T4 gets converted into T3, it doesn't really make a lot of difference in how we feel. So that's something to consider when you're in practice. If you're giving someone T4 and they just still feel cruddy, like their thyroid stimulating hormone might look great, like their TSH looks normal. But if their T3 is kind of bottomed out, then it means they're not converting, like they're just taking more T4 and it's not actually helping them to feel better.
So how do we fix that?
Yeah, how do you go?
Well, it's controversial. What I do is I give them T3. So there's T3, there's a synthetic form called leothyronine. And I would imagine that you guys will probably study leothyronine in pharm because it's more common, because we're finally recognizing, like the large endocrine societies are like, people don't feel good when we give them T4, what's happening? So you can do leothyronine, or you can do a form of T3 that comes from pigs. And that's the way that we've been able to kind of manufacture T3 that's natural. It's called either Armour thyroid or NP thyroid, Nature thyroid. That one's harder to get a hold of, but.
Are they prescription?
They're all prescriptions, although you can definitely get supplements that help to activate thyroid. Selenium is my favorite supplement that really helps T3, that helps people to like naturally convert T4 to T3. So there are supplements. You'll see like a lot of people that have thyroid disease, if they're feeling really bad, they'll take like a thyroid support supplement, and those thyroid support supplements tend to have like iron and B vitamins, selenium, things that like help conversion. It's all about converting that T4 to T3. Yes.
Question. So you said that the T3 medication that you give is come from the pork. What about if someone does not eat pork?
So
how
that's
do
a
you
good,
get it in?
yep, so that's a good point. So then it would be the leothyronine, because that's synthetic. Yep, so you would give the T3 that's from, because that is definitely, telling patients where it comes from in all medications is really important. They're hormones of any kind, and obviously thyroid's a hormone, a lot of times if they're natural, they come from animals, right? We're not getting them from humans. So letting patients know where it's coming from is really important. It's a good point. But we have usually a synthetic option, because humans are amazing. We create them.
What's controversial, just that for so long we treated with T4, so is it?
Yes.
Yeah, no, it's controversial.
So, and if you're not monitoring what the medication is doing and you stimulate and you give someone too much T3, that's bad. And you can put them into cardiac conditions. You can do the things that occur with someone's hyperthyroid by giving them the medication. So the American Endocrine Association, they're coming around. They're like, oh, people feel better. And it's not all people. Like if somebody can convert well, great. Just give them levothyroxine. It's awesome.
So if they don't really convert or get any better, is that a referral point like goes to endocrine?
Yeah, I mean,
You just continue on.
but I'll tell you that like most endocrinologists won't give them T3.
They'll just
They'll just keep giving them more levothyroxine. Yeah.
Wow.
Yeah.
Why, if they're not seeing?
If they're a really, really good endocrinologist, which I had the pleasure of working with one in New Mexico, he was very like, I just want people to feel better. If that's how they're gonna feel better, we'll just monitor them. And he was fine doing that. So you can find them, but they're harder.
Why don't they want to give T3? Is there some kind of?
She just said it can cause it.
Yeah, so they don't wanna put them into a hyperthyroid state. And you're gonna have more likelihood of doing that if you're not monitoring them closely
When they're
and.
taking too much of
Yeah.
it? Okay, so basically, I get what it is, okay.
How often are you monitoring, like 6 weeks or more than that?
If there's a change in dose, yeah, that's like a really good point. So for anything that's hormonal, I generally suggest that if you're gonna give any type of hormone medication, you check labs after 6 weeks. It usually takes about that long for it to reach like peak effect where someone's gonna stay. And then anytime you make an adjustment, you do that. But if somebody's been stable, I mean, I have patients that have been stable on their thyroid medication, and I'll check them 6 months at first, and then even sometimes once a year if they're doing really, really well, they've been on that dose for a really long time.
It's probably not just gonna all of a sudden change,
Right.
if it's being effective.
Yeah. The only caveat, so what can you guys think of as like something that could impact that? Like what could change in someone's situation where you might wanna check it? Check things like hormones more sooner.
Or anything else.
That's where I'm getting to. Yeah, pregnancy, that's really good, Kayla, absolutely. It's not what I was thinking of, but that's a good appetite. Like that.
Menopause or.
Weight loss,
Oh,
weight loss or weight gain, right? So in a year's time, someone could potentially lose a lot of weight or gain a lot of weight.
Skip periods.
And yeah, and we know that impacts because it's all cholesterol, adipose. So just think about that. And sometimes that's good to counsel your patients, like, hey, I'm not gonna see you for a year, but like, if you, like maybe they have weight loss goals and you're like, if it goes really well, like you need to come back and see me because probably you're gonna have to adjust their medications. So just keep that in mind. They're really good questions. Thank you, Kayla.
So levothyroxine, so I've noticed that sometimes we give it to people with renal failure. So we have some kiddos that we put them on levothyroxine.
Because the liver is really important in metabolism of T4 to T3. It's the gut and the liver, so probably they're not converting.
Renal failure?
Potentially.
Okay.
And so you're giving them the levo to give them T4. I don't know what a difference that would make. I'm not familiar with that population, but that's what I assume. So if you're giving them levothyroxine, then it's probably that they're trying to give them additional T4 because there's something that's disrupted between the thyroid to the liver.
Okay, well, that's all of the babies, we all have levothyroxine added to the medication.
Yeah, so I don't work in that population, but that's the assumption I would make because the liver is really important in hormone production too, the liver and the gut. I mean, the whole GI tract is really important.
So if someone's not converting, their T4 will be within range, but their T3 won't.
Exactly.
But like,
So you can get somebody that,
still just keep giving them T4,
Yes.
and like what is their explanation for T3? You know what I mean, like the low
just that
numbers.
it's like normal, because normal is between 2 and 4.
Oh,
So someone will be normal.
they have a very low and
Yes.
normal.
Yes.
Low, yeah.
Yeah. So it's like these little things, and I'm sure this won't be on boards and probably like totally confuse you guys, but these little things when you're a clinician and you're in practice make a big difference for patients. Because someone will just like keep giving them T4, their T4 will be really high, their thyroid stimulating hormone looks normal, and their T3 is like as low as it can be, but still in normal range. That's somebody that
Feels like crap.
feels like crap, exactly. So
They're
that's
not processing the T4 that you're getting.
exactly. So their T4 is just like T4, got plenty of T4, but they're not converting it. And that makes sense with the feedback loop and everything we talked about. But that's why sometimes conventional medicine is not, sometimes you have to like go beyond what the labs are telling you, because the labs are normal, but you really have to think. And maybe somebody has labs like that, but they have no symptoms, they feel fine. Great, they feel fine with like a really low T3, it's fine. Just keep them on what they're on, they don't have any symptoms.
Yeah.
So it's really these patients that are symptomatic. So here's a really nice picture of that whole, what we just talked about, TSH to T4 to T3. So you'll see liver and muscle, right? So gut and muscle, you need those things in order for T3 to go out in the system and impact all of the rest of our bodies. So this is like a more complicated picture. And iodine is really also controversial in thyroid management. You'll hear, I would say like anecdotally in practice, about half of patients feel better when they take iodine, and about half of patients, it really makes them feel horrible. So it's kind of up to you. It's not my first go-to because I've seen what happens to people when they start taking iodine and how horrible it can make them feel, so I don't usually do it. People will come to me taking iodine supplements, and I'm fine with that because they've been taking it and it works for them. But it's not something that I necessarily go out of my way to do because it's just the percentage of like most of the people get better isn't there for me, but this is how iodine plays in because you can see all of the iodine molecules. So it does make sense. So the time to get patients is before they have active thyroid disease. So you want to make sure that someone isn't iodine deficient before they actually have active disease. So if somebody comes in with thyroid-like symptoms, you might want to have a discussion with them about iodine. Would be reasonable. That's a better time to do it than when they're actively being treated.
So iodine because of the hypo?
Yes,
Okay.
more likely in a hypo condition. But it can impact either hyper and it just impacts the conversion of T4 to T3. So you just have to be really careful with iodine. Again, as a newer clinician, I would never tell someone to take iodine with thyroid disease. Just don't do it because it can get you where you're making somebody feel more crummy. TBG transports T4 and T3 to the body tissue, requires estrogen for synthesis, and it increases during pregnancy. There's a small amount in circulation. It has a high affinity for T4. Approximately 70% of T4 and T3 binds to TBG.
So you're just looking at that, if you don't produce estrogen, how does that affect the thyroid?
It's all connected, right? So I think that's why there's more, I don't have any proof, and maybe there's been something written in the literature, but I do think that's why thyroid disease is so much more prevalent in women, because we have more hormones. So like that impact.
So that's why they always want to keep checking with thyroid.
Probably. I mean, I tend to check women's thyroid more than other clinicians because I find things. I mean, if I don't find things, I stop checking, but I've found a lot of thyroid disease just by checking. So, again, if somebody is asymptomatic, like don't check things that you don't need to check. Someone comes into you and they're like, I feel amazing. Don't be like, I'm gonna do a full thyroid panel on you. Like that's silly. That's silly medicine. But somebody comes to you and they're like, God, I just don't feel like myself. I'm kind of foggy. I'm kind of tired. Just automatically check thyroid. And don't just check TSH, right? Because we just talked about why not. T4, 90%, it's a half-life of 7 days. T3 is really that powerhouse, right? 10% eliminated pretty quickly. So this, again, is like a really nice depiction of when you have sufficient dietary iodine. The main issue is that iodine used to be in our salts, and then we were told not to eat salts, and then so no one was eating salt, even though salt's actually salt. So it's like this, I feel like in our country we go to extremes, right? Like no salt, and then we're like, just kidding, have a little bit of salt, or like so. Talking about salt intake, talking about like other methods of getting iodine, those are important. I think that food sources are always a good thing to talk to patients. It's just supplements of iodine, but if they're getting it from food sources, great, encourage that. And then be mindful of salt, but salt's actually really important for us. Sodium's an important mineral for us. So, and then hormone synthesis, T3 to T4. These are, all aspects that are an important piece of hormone synthesis. And then metabolism of T3 and T4. And, talking about the liver causes hepatic glucose output, peripheral glucose utilization, increases of glucose, fat, and protein, absorption of carbohydrates in the intestine, gut excretion of cholesterol. I mean, it's so important. And that's why I think it affects us symptomatically when it's off. Affected systems and functions, you guys can review those. Pretty much all of the things, respiratory, cardiac, metabolism, GI, everything. If you had a patient come in that looked like this, I guess that would be pretty easy. Hopefully be able to direct them where they need to go. They don't look like this, ever. I mean, that's somebody who's let it go on for a very long time. So Hashimoto's thyroiditis is definitely the most common form of autoimmune thyroid disease, and it's what you will see in practice. I don't care where you're practicing, I don't care what you're doing as a nurse practitioner, you will see patients that have this and you will likely diagnose it in somebody if you're checking lab work. The one thing that I would add that wasn't on the lab findings is that I always check antibodies for patients because I think it's really important to distinguish if it's an autoimmune condition or not. And the only way to do that is to do lab work and actually check thyroid antibodies. labs make it really easy for you now. You can literally just type in thyroid antibodies. You don't need to know the antibodies, you just type that in, and almost every lab has the 2 antibody screenings that are important to check for hypo and hyper. So Hashimoto's, obviously hypo, and then Graves is hyper. Graves, you really wanna figure out pretty quickly. You'll have a patient, I guarantee you, I mean, it happens to most clinicians, if you've been in practice long enough, who comes in thyroid storm and you diagnose them with Graves, because people get really, really sick really, really fast. It's really scary. And you need to get them to the hospital, because you can't manage that in a non-hospital setting very well when it gets like to that point. And then primary max edema, autoimmune thyroid cell destruction. So the autoimmune conditions are important, and I just think that it's important for patients to have information about whether or not they have an autoimmune disease, because we know that if they have Hashimoto's, they have higher rates of having other autoimmune conditions versus if it's just a straight non-autoimmune thyroid disease. The care is the same, but you might have different conversations with those patients if their antibodies are negative.
So the only reason, this might sound like a dumb question, the only reason why you call it Hashimoto's or Graves is if the antibodies are present.
Correct.
Otherwise, you just
Yep. So you can either call it non-autoimmune thyroid disease, or just hypothyroidism.
Okay.
Hyperthyroidism. That's not a stupid question. It's a good question.
Sure wasn't.
Huh?
I said it sure wasn't, because I was just thinking like, wow, how do they just ask? I was like, oh, great.
And then too little hormone produced is what happens in hypothyroidism. Inflammation of the thyroid gland is the Hashimoto's thyroiditis. Medical treatments, that's not, I don't know why that's in the wrong place. I don't know why that's there. So those are the treatments for hyperthyroidism. I'm sorry. So if you guys have that PowerPoint, can you delete that part? Because that's not for hypothyroidism.
Is it hyper?
So medical treatments, those are for hyper, would be surgical interventions and the radioactive iodine. So with hypothyroidism, what is the treatment gonna be? Anyone?
Hypo.
Hypo, low.
T4 or low levothyroxine.
Yeah. Right, that's pretty much standard treatment. It's just give them the hormone that they're not making, right?
So you would just do a whole blood, you would do a T4, T3, TA7, you would just do a full thyroid panel plus antibodies?
So it really depends. When you guys first start practice, I would do free T3, free T4, and TSH, and that's it. And then if it comes back and it's abnormal, then I would do antibody testing. I've been doing this long enough. I have a pretty good idea if someone has thyroid disease, just because I've been doing it a really long time. So I'll check the antibodies when I'm checking, because I don't know. I didn't when I started though. So starting out, if you do the T4 and the T3, you're gonna be really serving that patient, because you have so much more information, right? Because now you know, your T4 is really high, but your T3 is super low, and your TSH is kind of in the middle, and you have tons of symptoms. So I'm gonna go ahead and do some antibodies. And then a lot of times those patients can have positive antibodies, and we call that euthyroid, meaning the thyroid looks normal, but they have antibodies. So if you have antibodies, what's probably gonna end up happening?
It's coming.
Get it?
Yeah.
It's coming. It's
Working on it.
gonna be there, unless you can take certain interventions and certain nutrients and certain dietary changes. We know that gluten is super inflammatory for patients with Hashimoto's. That's been proven. There are studies on it. So they have a higher incidence of celiac disease. So there are changes that you can help them make before it even becomes, and maybe, sometimes it never happens because they make the changes they need to make.
So you're saying thyroid leads to celiac?
So if you have thyroid, if you have Hashimoto's, you have a higher likelihood or chance of having celiac. So in a lot of patients, exactly. It's all the autoimmune conditions. And so if they're symptomatic, again, if someone is I have thyroid disease, but I have no GI symptoms, I poop every day, it's amazing, then don't test them for celiac. They don't have celiac. They're I eat gluten all day long. They're fine. But if they're I have GI upset every single day of my life. I feel horrible all the time. And you just diagnose them with Hashimoto's, then like move forward with that. So hypothyroidism, again, because of that negative feedback, you're gonna have that elevated thyroid stimulating hormone and then the low free T4. So just, I don't know, sometimes people just remember it really easy and sometimes it just won't stick in your brain. So if it won't stick in your brain, just write it over and over and over and over again. Hypo, high TSH, hyper, low TSH, because of that negative feedback.
Is it always free T3 and T4 in labs? Like when you're saying free, like sometimes it's written free and sometimes it's not.
That's what I do.
It's always free.
That's what I do.
Oh,
You can check total.
Order them separate.
You can check total or
What's
free.
the difference? That's my question.
Free is like what you're using. It's what's in your
So
body.
why would someone not check free?
I don't know, because they went to another school of thought.
That makes
But
sense.
you will run into that where people are checking total.
Free versus total.
And in my brain, that
Doesn't make sense.
doesn't make sense.
Doesn't make sense to me either.
So
Because free is what's
like
using.
what's there, like what is actually happening in your body.
Yeah, that's
Primary hypothyroidism, you know, I will say that if you work in a population where you have a lot of patients with mental health issues, lithium isn't used as much, but I mean, when I started practice like 11, 12 years ago, I was working in a really low income, low resource area, and there were a lot of patients on lithium, and a lot of them had thyroid disease. Yeah. So those patients, if you know somebody's on lithium, check their thyroid. It's probably tanked. They probably like the impact on the brain. So just keep that in your head. And then iatrogenic, subtotal or total thyroidectomy, obviously, radioactive iodine. So what happens when you have Graves'? Like what are we trying to do? What do we end up doing with somebody who has hyperthyroidism?
something combined.
What was the question?
Well, so what happens with the treatment? So we treat somebody for Graves', and then what do we cause by the treatment? So treatment for Graves', like hyperthyroidism.
Can you get a thyroid storm, couldn't you?
Nope.
No.
So if you remove the power, so then they can go lower,
Right?
and so now we have to
Exactly.
yeah, go lower.
Yes. So we make them hypothyroid, right? So we either remove one of the lobes, or we remove the entire thyroid, or we treat them with radioactive iodine, and then they're now hypothyroid for the rest of their life.
Yeah.
And they're on thyroid medication. Does that make sense?
Yeah.
If we do that, sometimes you can actually treat hyperthyroidism just with medication, and that's like ideal. You just treat with medication to knock down the production of TSH. But you know, it's tricky, it's hard. I mean, I've managed a couple of patients like that, but ultimately they all ended up needing more aggressive treatment. We kept them for years, but then eventually the thyroid is just a really powerful gland.
What is the medication that's used?
Carbelogene, I'm gonna say it wrong. I'll look it up for you guys.
No, that's okay. I was just curious.
It's like Carbelogene, it's been a long time since I prescribed it. So you can give that medication and it basically reduces the production of thyroid stimulating hormone, or T4 and T3. And then the medication has tons of side effects. The people feel horrible on it, but you can knock it down, you monitor their levels, and then you can take them off of it after about a year. There's a whole protocol for it. So if you have a patient, you'll have to look everything up. And I only did that because we didn't have an endocrinologist. I lived in the middle of nowhere. Normally that would definitely be something that an endocrinologist would manage.
Cabergoline, Cabergoline.
Yes.
Cabergoline. How do you say that?
So that would be something that, unless you're like I was and you're living in the middle of nowhere, you're gonna be like, bye-bye,
Yeah.
go to the endocrinologist.
That makes sense.
But if you live in the middle of nowhere, you're gonna learn a lot of stuff. So, and they just kind of manage it. autoimmune disorders, and then infiltrative disorders, scleroderma, sarcoidosis. TSH deficiency, these textbook photos are like, patients don't come in looking like this. I mean, sometimes, and you're like, I know the answer, but usually it's not the case. So hypopituitarism, tumors, trauma, isolated TSH deficiency or inactivity, and then hypothalamic diseases. And then there's just kind of a quick interpretation. So that's the kind of chart that, like, if you feel like this is hard to stick in your brain, make charts like that, draw pictures like that, you'll get it. You just have to kind of do it over and over again repeatedly. And that's just kind of like under the microscope, Hashimoto's thyroiditis. Anything that's like overgrowth or inflammation, the cells always just look like crazy and on top of each other. So this is a 76-year-old woman with an enlarged gland, irregular surface, and firm consistency. Her TSH was 86. Normal TSH on this lab was 0.5 to 5.0 with positive thyroid peroxidizing antibodies. So Hashimoto's, right? Then these are symptoms. We kind of already talked about those. Hyperthyroid. I mean, you can see like in Graves, like, it's just like very, very activated. I will say that the eyes, you will see. I mean, people with Graves, usually they go undiagnosed for a period of time because, so what are some of the symptoms for Graves or hyperthyroidism? What are some of the symptoms that people feel?
Anxiety, shaky, like cold intolerance.
Do they have like a lot of energy? Are they like, oh my God, I'm gonna do this, I'm gonna do this, I'm gonna do this, right?
Yes.
So in our culture, we kind of like that, right? Like people kind of enjoy feeling a little hyper. So people will be a little hyperthyroid, not too bad, like not thyroid storm bad, but just a little bit. And they'll go on like that because they're like, I need stuff all the time. And that's the thing, you have to be careful with T3 because some of these patients, usually women, you give them enough T3 and they're like, I need so much stuff done. I'm so good. And they get into the room with you and you're like, oh my God, like you need medication before, yes. So that's something to kind of monitor. Yes, thank you, Kayla, fast heartbeat. You can have a goiter, more common in women over 20, still more rare. Hyperthyroidism is definitely a lot more rare than hypothyroidism. And then Graves and medications, pituitary tumor, all of those things. So just be mindful of that people can be hyper and monitor for that. Like if somebody comes in and they're acting a lot different, like you saw them once and they would chill and you see them the next time and they're not, something's going on. I mean, it might be a mental health thing, but it also could be thyroid too. So check those things. And then lab findings, you can also check because we talked about electrolytes, checking calcium, alk-phos, LFTs, osteoporosis, low cholesterol. We just talked about symptoms, and I would say you will see the eye changes.
They're bulgy, right?
Yeah, very bulgy. I just actually saw a patient last week and I was like, I mean, it wasn't my patient because I'm kind of shadowing right now, but I was like, definitely be checking thyroid on you.
How fast does that happen?
It's slow over time. But again, in our culture, we value people doing way more than they should. So when that's valued, that symptom. But if you have hypothyroidism and you're like on the couch all the time, people are like, what's wrong with you? Like start doing something. So it's a little.
How fast are the eyes bulge? That's over time too.
Over time. So, yeah, you're not gonna just all of a sudden have over time. Yeah, slowly. And then you can tell that's.
When they go back to normal once you treat it, or they're just like that?
Nope. And smoking, if they're smokers, makes it significantly worse. Like the ophthalmic reaction and issues with the eyes increases substantially with smoking. It's similar to like HPV. like HPV. We don't know what the connection is, but your risk of not being able to clear HPV is much higher if you're a smoker. Smoking's bad, don't smoke. Bad for so many things. So this is a really obvious goiter. Again, goiters tend to be pretty obvious, but thyroid nodules and things that occur in the thyroid gland, they're really hard to palpate. Like they're really hard to get to. So the main thing that I ask patients is if they have any issues with it clearing their throat, if their voice changes, if they feel like they have something stuck in their throat and it's kind of lower down, and you know they have thyroid disease or you're suspecting it, getting just an ultrasound. I've had a couple in my life, they're not bad. It's actually fairly non-invasive and it's just an ultrasound of the gland. It's a little uncomfortable, but not a big deal. So always keep that in your like toolkit. There's another, I mean, you can totally see this one. Like, they don't usually appear like that. Good pictures for a textbook, but primary maxedema. This is a 10-year-old severe hypothyroid due to the condition. That's like before treatment, after treatment. So if you work in peds, you might see this, like if you work with the pediatric population. Accumulation of increased amounts of hyaluronic acid and chondroitin in the dermis, which is interesting, right? Because everybody wants hyaluronic acid and chondroitin like as they get older, but in this situation it's not so good. And then animal model studies suggest that thyroid hormones affect the synthesis and catabolism of the mucopolysaccharides and collagen by dermal fibroblasts. I don't think you need to like know this level of in-depthness. And then those are some symptoms. And then hyperthyroidism, just some differential diagnoses. So again, like on here, anxiety disorders. You know, I think that sometimes the reason people have hyperthyroidism for longer periods of time is because we're like treating the anxiety instead of actually digging deeper. So always dig a little bit deeper. Sometimes it is just anxiety, but thyroid studies, and then you have the 24-hour radioactive iodine uptake scan. That's really important to do. Like if their levels are off, just send them for the uptake scan because that's gonna help you roll in or out so many things. So if it's a heterogeneous uptake, then it's multinodular goiter, and then if it's a homogeneous uptake, it's Graves' disease. The way that those scans come back to you, they'll tell you. You don't have to like read them. Like it'll literally be like Graves' disease. Like it will be really obvious. So just know that that scan is necessary in order to diagnose Graves'. Like you have to have that radioactive scan in order to like 100% diagnose it as Graves'. There's a thyroid nodule.
That whole thing was on.
They're big. So when they're big, they're easy to palpate, right? Because I mean, if you have this like, you know, some of those pictures we saw, they're not usually like that. They're usually like a really small nodule can really cause a lot of havoc with how the thyroid is producing. So, and usually they're benign. A lot of times they're benign. You will have patients with thyroid cancer, but oftentimes those nodules are.
And those tiny ones are the ones that you said could still cause some issues with like,
Depending on
clear my throat.
Depending on the location.
It feels like
It's just, yeah, we're just like,
Okay.
there's something in my, yeah. So workup, ultrasound, differentiating cold versus hot, like 30 to 60% of nodules are benign. In my practice, the percentages were higher. Most of the nodules were benign. Hot nodule would require further workup and then consider a fine needle aspiration. Those are very painful, very uncomfortable for patients. So when I first started, I didn't know that. And then after having multiple patients, I made sure that I let them know because sometimes the imaging centers don't prepare them and let them know that they should probably take some pain medication before they go. And that's it's really, really uncomfortable. It's very sensitive. They do, they try. I mean, but it's like, you know, oftentimes you're in this weird position and it's just really all the patients that have ever gone through that say it's really uncomfortable. I haven't had one, but that's just coming from patients. Investigating a thyroid nodule. This chart is is nice because again, it helps you like walk down that pathway. at some point, you're gonna kind of get kicked out of this pathway because they're gonna go to an endocrinologist. So. And then you have, again, thyroid nodule, TSH. If TSH is like not suppressed, then finding a biopsy kind of like walks you through that pathway again. And then this is like that FNA, but I mean, you can imagine like a lot of times it's like, you know, you're kind of cranking depending on exactly where it is and how posterior the nodule is, which makes it even more uncomfortable.
So who does this? You said you send them to have that done.
So they'll go to an imaging facility, but not all imaging facility does an FNA. So you have to send them to a facility that does. And once you've been in practice, you'll know which ones do and which ones don't. And if you stay here, and oh my gosh, like take your pick. There's like a million places. So this is another exercise. I think we might come back to this because I want to get through diabetes because we haven't even started on that. So we'll come back to this if needed. So parathyroid gland, responsible for parathyroid hormone, PTH. So the thing that you need to remember with parathyroid is calcium. Like if a calcium is elevated, the first thing you're gonna do is check PTH. Like you have to check that, and vitamin D, right? Like you need to check those things. If you know that, you're like, that's good. Like that's the big pieces that you need to know. So you have like that homeostasis. Again, like we talked about that last week, like that's where we wanna stay always. And then you have the stimulus of the calcium levels are increasing, the thyroid gland releases calcium. Calcitonin then stimulates bone. It's important in intestines, uptake in the kidneys. And then if you have low calcium, then the parathyroid gland releases parathyroid hormone, which is PTH, and then that increases calcium and uptake in the kidneys, in the intestines, and then stimulates release from the bones. And then you have like vitamin D being an active part of that too. So there are the little parathyroid glands. That's what they look like outside of the body. And then, so the chief cells of the parathyroid gland, there's 4 of them. They accelerate removal of calcium and phosphate from the bone. They reduce reabsorption of calcium from distal tubules, can result in an increased net loss of calcium in urine, and inhibit phosphate reabsorption in proximal tubules. Stimulates renal production of vitamin D, which stimulates active absorption of calcium and phosphate across gut mucosa. So really important, this little. So action of parathormone, bone, kidney, and then, you know, just basically just another model of the importance of calcium and how the parathyroid is contributing to that. Primary hyperparathyroidism, manifestations are like hypercalcemia, kidney stones. So if you have a patient that's just like kidney stones, like don't just keep treating them for kidney stones. Like don't Band-Aid things. Like you have to figure out what else is going on underlying that. And then just, again, surgery. Secondary, you know, and if any of you work with renal patients, which a lot of us do, poor calcium absorption and then inadequate nutrition, like a diet that's really, really low in calcium and vitamin D. And like back to vitamin D, which was how we started the night too. And then you have primary, secondary, tertiary, and then paraneoplastic. Clinical features, so weight loss, back pain, cardiovascular, heart block, musculoskeletal. This definitely doesn't tend to be like the first place somebody checks. It's really calcium. Like that's gonna be the thing that clues you in. Mild elevation, like, you know, usually it's like 10 point something, that's like in normal range, like the high end normal. So if somebody's just like 0.2 or 0.5 outside of range, maybe not, but I tend to just go ahead and check a PTH if somebody has any of these symptoms and their calcium's elevated, especially if they're not on a calcium supplement. You'll have like older patients that will be taking calcium for bone health. And sometimes it's just that they're way overtaking calcium because we get a lot of calcium from our diet. So always ask them that first. So if I have somebody that's on supplementation, I'll ask them to stop it. I'll be like, hey, your calcium levels look fabulous. Like, stop taking your calcium. And then I'll repeat it, you know, in like 2 to 3 months. And then if their calcium levels then are like completely normal, like they're good, like better than having to. I'm gonna write down this, but I wanna keep going because again, we haven't even gotten to diabetes. Just kind of defining these, again, these exercise slides are really good for practice and study, so go back to them. And then the adrenal gland, and kind of where it sits, where they sit, mineral corticoids like aldosterone, and then the glucocorticoids, cortisol. I feel like cortisol is like way more in the minds of people because people will talk about having like chronic fatigue syndrome and like my cortisol levels, like they must be low. It's like, they probably aren't because you don't have Cushing's or Addison's. Right. So when patients come in and they're like, yes, I definitely have chronic fatigue, I tell them, I'm like, yes, you are tired all of the time. That's very different from having an adrenal disease that causes serum levels to be very abnormal of cortisol. So just helping patients differentiate those and then also letting them know that you believe them. They're tired all the time. It's just not a condition. Yeah. And then you have the gonadic corticoids. It's 9 o'clock. I'm losing my brain. Or the androgens. So adrenal medulla, where epinephrine and norepinephrine. Cushing syndrome, so this is kind of like stereotypical. I didn't see a lot of this in family practice, but knowing these basic tendencies, like with the moon face, the buffalo hump, all of those changes that happen to the system are going to be important because you'll probably have a question on Cushing's and Addison's. Like that would not surprise me that would be on boards. So there's your kidney, and then there's little adrenal gland. Just got it.
What is that?
And those are, the adrenals outside of the body. So this is really great. So that's kind of like normal. And then Addison's is like depleted, and then Cushing's is like, very enlarged. So, and then Addison's disease, where you don't have enough cortisol. So primary adrenal insufficiency or secondary adrenal insufficiency. And with Addison's, it makes sense that you would feel all these things, right? Like you're just fully depleted because cortisol is our energy hormone. So if you don't have enough of it, you're gonna just be, and then everybody always thinks of JFK because he had Addison's. I think he hid his symptoms really well. He seemed like he had plenty of energy, but I think he was also being treated. So, workup, if you suspect somebody, like if somebody comes in and their cortisol level is completely out of whack, that's another one that you're gonna be like, you're going to see a specialist now. And you can definitely, you'll probably, if you're checking cortisol, you've already checked a complete metabolic panel. It's not like you just go straight to serum cortisol. Like that's a test that you're holding off on and then doing a CT and then an MRI. And then, it says consider referral to endocrinology. No, you can do some of the imaging if you want to, but I would do that while you've already had the referral to endocrinology in place. Yeah. And then the pancreas, wreaks havoc for a lot of people. The islets of Langerhans, alpha cells, beta cells, and then diabetes mellitus. The gonads, responsible for estrogen, progesterone, and testosterone. And then one of my favorite hormones in the world is testosterone. This is kind of like the male hormone pathway. And I think we'll get into this more in gynecology, so I'm not gonna, go too into depth in that. The pineal gland, melatonin influenced by light levels, thymus gland. I think, just knowing these basic slides will be important. So just like writing down thymus, this is what it does. Pancreas, this is what it does. This is how it's involved in the endocrine system, be important. And then metabolic syndrome, right? Like I'm sure you guys have all heard of that. Metabolic syndrome is something that's really important to treat. So you're gonna have insulin resistance, you're gonna have a cholesterol panel that's abnormal, you're gonna have hypertension. They're gonna have abdominal obesity though. It's really important that it's abdominal obesity. There can be genetic factors, and obviously if you have those things, you're gonna have increased inflammation. Like your body, your whole system is inflamed at that point. And then this is something to definitely study, go over this if you have any, like, what is the ominous octet? Know the ominous octet. So muscle, you're gonna have insulin resistance, liver, insulin resistance, you're gonna increase glucose production, pancreatic B cells, going to decrease insulin production. The nervous system is dysfunctional neurotransmitters, kidney is gonna increase reabsorption of glucose, pancreatic alpha cells are gonna increase production of glucagon, adipose tissues enhance lipolysis, and then the small intestines deficiency of the incretin effect. So knowing these things is important because it's gonna help you with like what the heck is happening when a patient has diabetes, like when they have metabolic syndrome. Like what's happening, how are the organs? And so another exercise, again, this will probably be the one if we have time at the end that we definitely will go back to. I want you guys to really know that, but we'll also talk about it. But I would do this exercise specifically before you take your quiz done. So just make sure you know that one. Metabolic syndrome, 3 out of 5 characteristics. Again, usually if patients have 3 of these, they're gonna have all 5 of them. It's really rare that they don't. Like if somebody comes in and they have that abdominal obesity, they're probably gonna have the rest of these factors with the elevated triglycerides, and HDL, or that high density lipoprotein that's not high, which that one is the one that we want to be high because it's protective, an elevated blood pressure, and then a fasting glucose that's elevated. So you don't have to have an A1C for this, you just have to have a fasting glucose that's outside of normal. And then metabolic syndrome, symptoms are fatigue, and then signs of central obesity, the acanthosis, nigricans. Does anybody know what that is? Practice at all? Anybody online? You guys are probably like asleep. So that's where you get kind of like this darkened skin color. Yeah. So you guys, once you see it, once you see it in practice too, you're gonna never forget it. You're gonna be like, oh yeah, that's what it is. Yeah. So now you know words to right. That's why we go to schools, have medical terms. And then PCOS, the polycystic ovarian syndrome, with hirsutism. I know what hirsutism is here. Yeah, so unwanted hair growth, right? Then the central obesity or adiposity, and then the abnormal labs. Again, insulin levels aren't something that have been evaluated. I actually check a fasting insulin on a lot of people because just like checking ferritin, to me, a fasting insulin is a much better marker than an A1C because by the time someone has an elevation in their A1C, their fasting insulin has been elevated for a long time. So if you have somebody that's has a family history, they're super concerned, they're just wanting to check things, their A1C is maybe 5.6, which is technically normal, you might consider checking a fasting insulin. because I bet you it's really high. And then you can give them additional education. You can be like, fasting insulin's really high, which means you are at a much greater risk of having diabetes, so let's make some changes now. People like having numbers, it helps them make behavior changes. And then education, prevention, again, lifestyle, genetic influences. There's a lot, like at my clinic, we're using a lot of semaglutide or Ozempic or Mounjaro. It's amazing. Like this medication is like insane, works better than anything I've ever seen for weight loss, because you'll have patients come in, they're very frustrated, they've tried everything, every provider they go see is like, well, eat better. It's like the stupidest advice ever. It's like, okay, like I haven't tried that. So the GLP-1, that class of medication is really helping people, really helping people to get them motivated. And what it does is it's actually helping them change behavior. So it shouldn't be a medication that they're on forever, but sometimes it's really hard to change behavior. We use medications to help with that in so many other ways. It seems silly not to use it to help people with weight.
Which is not nice.
Semaglutide. So semaglutide is the generic, even though there's not a generic, but Ozempic.
My coworker's taking it. She was 150 pounds. She's skinny now.
It's great. I've been in practice for a really long time. I've never seen a medication work like that. So the other piece of the GLP-1s though, and what has been really challenging is that you can get them from compound pharmacies, which I actually recommend to people because Ozempic and Mounjaro are medications for patients with diabetes. So getting them from a compound is more responsible because then you're not taking them from patients that have diabetes. Like if they have diabetes, that should really be the first line. Like you have diabetes, you really need these medications. And then second line for the people that are using it strictly for weight and they don't have diabetes, then they can get that from a compound pharmacy. Costs more, but just in terms of the morality of like, what are these medications, who are they meant for? If that's something that you as a clinician or your patients are thinking about, until they can make more.
I want that thing. So because she said that she had to meet the level of being severely diabetic and weight, and so in order for the insurance to her BMI has to be severe. So
But there's plenty of clinics that are doing
And they're doing the compound. So they're doing the compound formulation. So then you're not taking the medication. Like it's not covered by insurance. So you have to.
I have to pay you $200-something.
200.
She's got
They're finding for 200. I think you go do that.
I know,
I've heard that it's
I heard
really
it was
expensive.
because when I
She said her copay is $1,000.
Oh, copay.
Well,
So Ozempic and Mounjaro are very expensive.
Yeah, it was like, because she was like, I was like, oh, I'm doing it for like $1,200. I'll just change my eating habits.
So that's the thing is like, yes, like if you can change your eating habits, but the thing is that to get somebody to where their blood pressure is low, their cholesterol is low, like you have to have weight loss. You really do. Like if that's happening in your system and you have metabolic syndrome, there has to be weight loss. So it's like we have to give people something.
Right.
And yes, if I could make everybody eat the way I eat, I would love that. But it's really challenging. And then you also have people who are not resourced with, I can buy good food for my family. I'm blessed to be able to do that. So I just think the more options we have, because weight loss can impact all of these things. And then hopefully you don't have somebody that ends up with diabetes. That's like the goal. So, and then again, PCOS, fatty liver, gallstones, asthma, sleep disturbances, some forms of cancer, and then we go into diabetes. So screening, risk factors, and again, I should say that these are all type 2, right? So making sure that there's a big, huge, enormous difference between type 2 and type 1. And I wish we lived in a world where no one had type 2 diabetes. That would be fabulous. But, the reality is that we have lots and lots in front of us to make unhealthy choices and very little in front of us to make healthy choices. And our insurance companies don't help. They don't pay for things that are preventative. They pay for medication. So, definitions, you guys can review through those. So type 1, most common before the age of 30, and type 2 if you're working in a pediatric population or family practice, like this should always be your top one differential for a kid. Like a kid comes in, I mean, usually these kiddos, unfortunately, because kids are just so resilient, they just bottom. It doesn't, I mean, usually it's hospital, like straight to the hospital and then to, and then out. So it's rare that they're gonna, it's great if someone can diagnose them early, but it just doesn't usually happen. And then so type 1, type 2, maturity onset diabetes if you're young, and then gestational, right? And if you have gestational diabetes, then it increases your risk substantially to have type 2 in the future. The pathophysiology of type 1, autoimmune beta cell destruction, slowly or rapidly, features not evident until approximately 80% of the beta cells are destroyed. So you can have patients that have type 2 diabetes and it's gotten to the point where then they are actually type 1. Like they can't survive without insulin any longer because the pancreas, those, the beta cells have been just completely destroyed. Genetic, there's multiple genes. Most don't have a first degree relative with type 1 and they have an increased risk compared to general population. There's a concordance with identical twins of 30 to 70%. So there's obviously like modifying factors. Environment, I don't know. I mean, viruses are really crazy what they do to the system. I have a woman that I went on a mission with, and her son, who was 13, had COVID and now has type 1 diabetes. Like literally it was from COVID. Like that is the only thing.
Pediatric endocrinologist said it's happening.
Yeah, it is totally happening. And it's really scary. And so it makes sense that because we're seeing that with COVID, likely these other viral infections that maybe aren't as like potent as what, or as like disastrous on the entire endocrine system as COVID is, probably contribute to kids being more susceptible and then ultimately developing type 1. And then autoimmune beta cell destruction. So probably something that maybe we'll see more. PCH during COVID, we had a lot of new ones that, yeah. I mean,
Tons.
COVID. And then obviously like diagnosing. And then anti-GAD, it just kind of goes into anti-GAD, the presence of those antibodies in the blood are an early indication of the start of the process. DKA signs and symptoms, the symptoms and signs. I mean, again, kids are just so flippin' resilient and they'll just, be incredibly symptomatic, but won't necessarily say anything and then take them to the hospital. Yeah. Random blood sugar sometimes. A lot of times I think athletes are screened. I don't know why we don't screen all of our kids the way we screen athletes, but if they need that sports physical, a lot of times they'll have a urine on that sports physical, so sometimes that can be a method. But again, usually we're not screening them until they're past the point like in their teenage years. And then type 2. I've definitely seen type 2 not only in like with obesity, I've seen it in other patients. So don't just, and then I've seen patients that are very, very, very large and heavy patients and they're fine. Their blood sugars are fine. So I think we need to be really mindful of being like, oh, they probably have diabetes. No, like there's so many other factors that go into it. So just be mindful of
I think
that.
blood pressure's that same way. We have to be really careful with blood pressure.
Yes.
Because there's really heavy people who don't have blood pressure issues.
And really, really thin people.
who do, yeah.
Yes,
I
absolutely.
think sometimes mentally we think, well, if you lost weight, then it's not always the case.
This isn't, that's true. There are a lot of other cardiac conditions for sure. And then those are kind of like levels of glucose. And then diabetes signs and symptoms, kind of the risk factors. I feel like we all kind of have a pretty good sense of type 2 diabetes. I think we know about it better than a lot of the other endocrine conditions. And then we do that to prevent chronic complications, right? That's why patients with diabetes, we need to be getting vision exams once a year. We need to be checking their feet. Any patients that I saw with diabetes, they just knew, and they would just have their shoes and socks off when I came in. So I did a lot of management of patients with diabetes in family practice, and they just knew. I mean, they knew I was going to look at their feet every time. It's so easy. Like, you literally just have them already shoes off, even if your appointment is 10 minutes. They lift up their feet, you look at the bottom of their feet. Encourage them to wear white socks, because if they're wearing black socks and they have a cut or something going on the bottom of their foot they can't feel, then they won't see it. But if they wear white socks and they take it off, then they might see, like, so I would always encourage them to like look at their socks. So it's just a little trick if you are working with that population. And then complications, you know, cardiovascular disease, and then I just talked about, and then obviously like renal function and the neuropathic pain that is can occur as well. Eyes, kidneys, heart, and lower extremities, right? That's like what you want to be checking with these patients. And then other complications, gastroparesis, sexual dysfunction, dermatologic changes. I will say that sometimes those sexual dysfunction for men, I mean, I've been able to help men change their lifestyle habits with that. Nothing else worked. And then I'm like, you know, like you may like have erectile dysfunction just based on how high your sugars are, like not right now, but over time. And that really helped them to change. So you just have to find like what's the motivator for change. I mean, you guys have probably already done like motivational interviewing, right? Like it works. I mean, you just have to find what's the piece that is maybe gonna help them to make some of those changes. And then prevention of chronic complication is the entire focus of managing diabetes. And I know this is under type 2, but it's type 1 too. I mean, I also worked with a lot of adolescents, you know, in their teenage years. Yes, Susan, exactly what matters most to them. And it's really hard with teenagers because they don't want to do anything that they're told to do, and that's normal. Like, they're actually doing normal adolescence, but when we're talking about they have to have insulin, it's really, really challenging. So, and for all of these reasons, you know, because you want to protect their functioning for the long, you know, years and years and years and years. But when they're teenagers, it's really, really tricky. So for them too, you have to figure out what, you know, they'll oftentimes have higher A1Cs, and it's fine. Like their A1C might be 8, but at least like you're working on like the rest of it, and you're helping them to use their machine and all that. And then there's just like basic, like an A1C of 7 is an average of about 150, just to give you an idea. Patients will want to know that. Goals for A1C, you know, less than 7 or less than 6.5. It's really hard to get patients in those ranges. You have to really have somebody who's motivated to do the work. And when they are, I had a patient once, her A1C, she was from Mexico, and her A1C was like 14, I think, or 15. I don't even know. It was like so. And she didn't know she had diabetes because they hadn't checked her in Mexico. And her A1C went from like 14 or 15 down to 7 in 3 months. Never seen anything like that. I put her on insulin. She did every single thing I told her to do. I saw her every month. She did every single thing. She completely eliminated sugar. She did all the things. And so it is possible. Like that can happen with these patients. So just know it's possible.
So she reversed? She went back to 7 instead, or?
Yeah. So, I mean, she has diabetes, like she's gonna need medication, but then we transitioned her off of insulin because she didn't need the insulin anymore, and we used other medications, and she just didn't know. Like, she had no idea that was happening. And she was one of those that her A1C had been so high for so long that she was muscle wasting, so she was really skinny. She was like super, like she wasn't your, again, it's not, don't just look at body happiness. There's a lot more into it. And then screening on all individuals. I kind of talked to you about my philosophy on checking fasting insulin. I just think it's a biomarker. And then diabetes type 2, the glucose tolerance, you know, I mean, pretty much like fasting insulin and A1C. Diagnostic criteria, things like this might be on your boards. They really like pulling questions like this. So just kind of know these 2-hour glucose tolerant tests, fasting blood sugar greater than 126. So just kind of have an idea about those values. And then you check your A1C every 3 months. Every 3 months. So A1C is every 3 months, no sooner. Insurance will not pay for it. If you check it in a month, it might be changed a little bit, but it's not sufficient enough to justify checking. It's really
like the whole reason is like over a 3 month
Yes.
span of it.
exactly. The A1C measures the average glucose over the previous 3 months. So sometimes you'll have patients that are like, I just ate. Like that's why my A1C was high. You're like, no, it's not. So knowing that is really valuable. So you can explain that to them.
My insurance will only cover it 3 times a year. Yeah, like a type 1.
I mean, that's like really stupid.
It's really stupid. Insurance is so stupid.
I
So
agree.
many levels.
Just wait, when you're a provider, you might even
I already
think
hate
it's more. And then, other diagnostic tests to consider: sleep studies, echocardiogram, stress test, carotid ultrasound if needed, EKG. And then exercise, so regular frequency is the best. Really all of the studies that are coming out is that we should be moving our body and having exercise 30 minutes every single day. There's no resting, like every single day, 30 minutes, because we are creatures of habit. And if we don't make a habit of something and we just do it 3 or 4 times a week, then we're not getting as much of a benefit, and we'll do it less than that.
Working doesn't count.
Working does not count.
It's gotta be outside of your.
Everyone tries it, but no, everyone has that argument with me. But I work and I run around all over the town at work. I'm like, doesn't count. 30 minutes exercise.
Those legs be going.
I know people will show me the watch. They're like, no, but look, I got all these steps. I got so many steps. Yeah, I got 1,000 steps. Like, that's amazing. And you still have to exercise. So when we exercise, our main source of glucose is obtained from stored glycogen from the liver. And then insulin levels fall, and then increased insulin sensitivity can last 16 hours. So it's like so important. I mean, exercise is like, so that's my take on some of these weight loss medications too, is that our culture is so nasty to people who don't look a certain way. And so for me to have a conversation with somebody that's like, hey, I know you're not comfortable with your body, but like just go to a gym and work out with people. I mean, it's like, or be really motivated and just work out by yourself at home. I mean, it's really so much harder than that. So I think sometimes when we can help them a little bit, get some weight off.
Push, and then they'll like it.
Yes.
Yeah.
So there's that's kind of my feeling of doing this a really long time, is that it's really hard, some of the advice that we give to people. Like, you just do that, it'll be fine. I mean, we live in a culture that it's really, really hard to do those things. So just be mindful of that as a provider. Your patients will appreciate it. And they'll make changes because you're like that too. So these are kind of goals for where you want to be. And then hypoglycemia, really easy to treat this in a type 2. Type 1, I mean, it's a whole different ballgame. Like, or a type 2 would be because of type 1. It's those blood sugars tend to be a lot more laid out all over the place. And then hypoglycemia causes, you guys can kind of review those, why that might happen. Signs of hypoglycemia, and then central nervous system changes that can occur because of it. So those are the cascade of slides on the endocrine system. Are there any questions from anybody at home or from you guys on the material, other than your brain wants to go to sleep? Maybe Danny.
220. I know.
So the slides were with the exercises. Thanks, Carla. I would do, so that was like slide 147, slide 161, and slide 180. We didn't, take any type of break other than that 30, so I'm fine with us kind of like stopping here at like 9:45-ish. And then if you guys do those exercises at home, I would encourage you to do them. And then week 3 topic is going to be cardiology. I'll just tell you like straight up front, like that is like, I mean, there's gonna be one system that your like teachers are not thrilled about, that's fine. Like, I love the rest of the body, so you can like talk away when I'm talking. I will probably have us do some like group exercises and I'll make the PowerPoint as like involved and expansive so that way you guys get the material that you need. Because I'm kind of like using two different people's slides and putting them together. So if you have questions about the material as you're going through it, I would consider watching. I put the video and the animations and the watch these for next week on this PowerPoint, so you don't have to go in and find them if you don't want to. And then we'll get through it. I can teach cardiology for 4 hours. We will do this together. It'll be fine.
Slides you were saying?
The slides with the exercises are 147, 161, and 180. And so those were like on parathyroid, and I think if you went through those, if you can answer all of the questions on the exercise slides, you're doing pretty good. So you'll have, I'm probably gonna take these slides down like tomorrow morning. So whatever you need to get from these slides, try to get them tonight or tomorrow morning. And then I won't upload the slides for next week until like Thursday morning. So for those of you here, you'll have time to download it before you come in, so you have access to it. But I probably won't have them available to you until Thursday morning. And then with the quizzes, you know, just don't hesitate to reach out to me if you have questions or something's not making sense or fitting. Okay. Yeah, I'm tired, so I'm sure you guys are tired. And then I will see you guys next week. If there aren't any questions.
So we downloaded these, then we'll lose them, so later.
Yeah, I'm just taking them off of there because they're not, like, I don't own those slides, so. The generosity of others. Okay, I'm shutting down this one. So if you guys online have any questions, just let me know.